I got to get YouTube right here too. Ah, nope, that's wrong. All righty then. Well, now, hello. Let me, if I move, see, I gotta move. See, I'm a little distracted because Mom fell. All right, this is it. This is what you have got today. So anyway, hello, my friends. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the National IC Support Group leader. I like to do drop-in meetings on Sundays just to see how you're doing, to see if anybody needs any help, any questions, if we have any newly diagnosed patients. My goal in doing these meetings is to make you strong, knowledgeable, and informed so no one can mess with you again, right? So no one can mess with you. I don't want anybody to insult you, to demean you, to tell you that it's all in your head, to tell you that you're damaged goods. None of that. This is real. This is treatable. This is not all in your head. And normally when I do these meetings, I do a little 30-minute intro, and then we'll happy to take your questions. Granted, we are all now after a long winter starting to enjoy the summer, or at least warmer months. And if that's the case and we want to be outside, please. Hello, Danielle. Nice to see you on YouTube. How are you? So, an interesting study crossed my desk this morning. And we got quite a few people asking about our diet apps. We have a diet app. Actually, it's very popular. So we have a diet application for Android and Mac. And then we also have a wonderful bladder tracker app. They are all free. Hello, Deb from Canada. Nice to see you. But one of the links are messed up. If you just go into the Google Play Store and do IC Food List, see if you can download it that way. Because it is there and it's been there for a couple of years. There's no doubt about that. All right, hold on one sec. I want to see if I can find this research study. Because I was looking at it on my iPad, but now my mom is using my iPad. Well, okay, anyway, the gist of the study, we are all trying to understand, why does, hello, Gay from Texas, why do patients who get bladder issues also end up struggling with bowel issues? What is the whole IC-IBS connection? And of course, we also have the IC endometriosis connection, which is also a bit of a mystery. And I have a new product to tell you about for that. But anyway, so our operating assumption has been that it's all about nerves talking to each other. We know, and I have a picture of this. Let me see if I can do this. Yeah, here it is. All right. So we know that the nerves in the bladder and the nerves in the bowel merge at the spinal cord. They actually end up going into the same nerve root at the spinal cord. And we know also that nerves talk to each other. That helps us understand allodynia. If you've got an injury, let's say you've got a really bad injury on your hand. Okay, so first your finger is going to start hurting, but then your hand might start throbbing. That's because the nerves proximal to that original injury have become inflamed. Then your arm has the potential of becoming very, very inflamed. That nerve sensitivity can spread peripherally all the way back to your spinal cord, and then it can start affecting nerves at the spinal cord. This is a fabulous book by Dr. Angie Storr in Texas. And, I learned a lot from this little book. It's super easy to read. It's in the IC Network shop. Let me see if I can grab this picture and see. See, there's kind of that example. So what's fascinating here is that the assumption here, the operating assumption that we've all been working with, is that a sensitized nerve from the bladder, that sensitization goes up to the spinal cord, and then it hits the bowel. Hello, Mina from Uganda, Africa. Are you an IC or pelvic pain patient? This is a support group meeting. Let's see here. Where's this picture? Come on. You know, normally I use these pictures all the time and they pop right up. Where is it? Oh, come on, Jill. I know it's right here. I know it's in here because I refer to this book all the time. No, that's not it. Oh, here it is. All right. Okay, so this is an example of all the peripheral nerves down in your pelvis and now how they all migrate up to the same node at the spinal cord. So we have been operating on the assumption that that the bowel-bladder connection is really about nerve sensitivity, just proximal nerves becoming involved, et cetera, et cetera. But this new research study was talking about the brain, bowel, bladder axis and the influence between the three, but it's not going to go where you think it's going to go. It's talking specifically about alterations in the gut biome, that when the gut biome is under stress, that underlying process has a potential. So the gut biome in some way, don't ask me how. Hi, Kayleen. Hi, Ann. Hi, Kim. Don't ask me how. I don't understand the mechanics of it, but we certainly know that the gut biome, and it shouldn't surprise us because the brain is amazing, that somehow the brain is aware that there's a disruption in the gut biome. So when the gut biome becomes dysfunctional, let's just say you have a terrible diet, we've got other issues going on, toxic exposures, et cetera, et cetera. When the gut biome is damaged, the brain knows that somehow, that the biome is damaged. And somehow that then comes down and changes the way the bowel functions, but also the bladder. So they were very specific in saying in the study, they were saying, you know, and you know, I say this all the time too, let's not tell patients and suggest to patients, hey, this is all in your head and you've got control over everything, when in many cases we don't. We just don't. So the research is hopping right now. It is exciting. It is a really, really exciting time. And if you're on the IC Network mailing list, I have sent 3, if not 4 clinical trial announcements out in the last 4 weeks. These are opportunities where you as a patient can participate in cutting edge research, where you can be some of the first to try new therapies. And the advantage of participating in a clinical trial is it's free and you have the opportunity to work with some of the best IC doctors in the world. And there are clinical trials around the world. There are a lot of clinical trials in India, in Asia, in Europe, and of course here in the United States. And so if you want more information on clinical trials, make sure that you sign up for the IC Network newsletter, because that's how we send out the announcements. I have at least 2 more that we're going to be sending out, and then we're going to be doing an intensive clinical trial recruitment over several months for a very, very important and promising research study. Now, one of the last clinical trials that I sent out is what we call a phase 1 study. A phase 1 study is the first human study. So it already means they've done the animal studies, they've established some some solid safety data. We've got mechanism of action down. There's precedent. There's research. Good foundational research saying this is a really encouraging and optimistic treatment that's worthy of additional exploration. So in that phase 1 study, that's just a small number of patients, in this case under 10, and they will pay you up to $20,000 to participate. But it's work. I mean, you have to go stay at the research center for several weeks, and they're going to do a lot of blood draws because they just want to watch what the medication does in the bloodstream over time. It sounds daunting. I understand that. It is a phase 1 study. Every single therapy that's FDA approved has a phase 1 study. There's always patients who participate. They already did, if I remember correctly, their first round of phase 1 testings with healthy people who did not have IC. Now they're testing it with patients who have IC, if that makes sense. So lots and lots of good things. Now, one of the other great mysteries of IC is what is the whole IC endometriosis ovarian cyst connection? And this is there's a couple of really interesting theories about this. So endometriosis is a migration of endometrial tissue from the uterus up through the fallopian tubes and into the belly. And it can go everywhere. It can go all the way up to the lungs. It can wrap around the urethra, the rectum, all sorts of things. Endometriosis is absolutely brutal. The problem with endometriosis, the reason why it's so painful, is wherever you have endometrial tissue, whenever you have a period, it's going to bleed. And you're not meant to have blood in your open belly. And so if you have endometrial tissue that's migrated up towards your belly button, for example, and you have a period where you're having a period inside of your belly, and your belly does not like that, and that's what causes a lot of the pain. We have very clear data now on what we think causes endometriosis, and that is the exposure to estrogen mimicking chemicals. And it's a very interesting story because the endometriosis group and the IC nonprofits all got started back in the late 80s. I want to say late 80s, I think. Yeah, late or mid 80s. But the endometriosis group had an amazing breakthrough. They found in a little tiny chemicals medical journal a reference to endometriosis. And this was researchers who were trying to prove that exposure to dioxin is the most toxic chemical ever made by man. It happens when you burn plastic, and it goes up into the atmosphere. It spreads into the grass. The cows eat the grass. It gets into the cow's milk. It gets into the cow's meat, and it migrates up the food chain right back up into humans. And so in this study, the plastic manufacturers were trying to prove that dioxin was safe. And it was a monkey study, and one of the monkeys died. So they did an autopsy. What they found was that monkey's belly was filled with endometriosis. That shocked them. So they published a paper about it that I don't think they thought anybody would find, but the endometriosis patients found it, and researchers found it. Well, to make a very long story short, they were going to shut down the study. They could not say that dioxin was safe. The endometriosis people petitioned the government and said, before you kill these monkeys or sell these monkeys off, and please, I gave up a career because I could not do anything like that with animals. I am a pharmacologist. That was my specialty, drug development. I walked away because of animal research. This is a perfect example of animal research that's devastating. So anyway, they petitioned the government to allow these monkeys to have laparotomies so that they could look in their bellies to see if they too had endometriosis. And they did that. Every monkey exposed to dioxin had endometriosis, and it was a dose response curve. The more the dioxin, the more the endometriosis. So we now have, and why? Because dioxin is an estrogen mimicker. Every year or every couple of years, a new medication gets added to the endometriosis dioxin list, as known as the estrogen mimicker. And the problem, of course, is we have so much freaking plastic now introduced into just landfills and everywhere else in our, I mean, whether it's plastic that we're drinking water out of or plastic that's seeping into the water through landfills. We have royally screwed this wonderful planet that we're on with all this terrible plastic. So anyway, so theory number one is endometriosis is caused by plastics, the burning of plastic, releasing dioxin. Back in World War II, I think they had about 40,000 patients around the world diagnosed with endometriosis. Now it's many millions, and that kind of supports that. But of course, there's more research going on. The other theory about endometriosis, and this also kind of goes back, Kayleen, I think you'll get this, into ovarian cysts, is some research that is slowly being explored around a condition called porphyria. Porphyria is a B12 processing disorder, vitamin B12 processing disorder. And when you're deficient in B12, there's this very long chemical process that happens. And at the very end, you become estrogen dominant. There's too much estrogen in the body, which then they also believe supports, the growth of endometrial tissue. So anyway, I'm sorry. I love the science. I was going to. Kayleen said, I had cysts when my endo was so bad. I did too, hon. I remember I couldn't go through my finals, my second quarter finals in pharmacology when I was a junior, because I had like a dozen ovarian cysts and I had to fly home so they could decide if they were going to do a hysterectomy. Many women, we feel when we ovulate, there's a sharp little pain that lasts for about 6 hours. And ovarian cysts are like that on steroids. It is a very sharp pain, especially when you move your body. All right. So anyway, listen, enough on that. However, I will say we do have a new supplement that has just been created for patients with endometriosis called Endometria. And I will have more information on that soon. It's created by Natural Approach Nutrition, the same company that makes Bladder Builder and Bladder Rest. So that's very, very exciting. But I need to learn a little bit more about the method of action before I can talk about it well. All right, so let's see here. Hello, Kim from Kentucky. Hi, Ann. Hi, Kayleen. If I miss your name, I apologize. Hello, Janet. Hello. Linda says, what's a good time to call you or when you can call me at your convenience, honey? Afternoons, always. Afternoons, Pacific time. The best time. Mondays are my day off, so not on Mondays. Tuesday through Friday, and this is a good week for me. Let me look, and I can tell you. Let me look at my schedule here a little bit. Today's the 23rd. All right, so late afternoon Tuesday. I have a coaching already set on the 26th. I'm open on Thursday and Friday. Let me look at this one. And afternoon, so just late afternoons, Tuesday, Wednesday, Thursday, Friday are usually good. Okay. Hello, Heidi. It's always nice to meet another Heidi because I'm also a Heidi too. Diagnosed since 2009. They've tried many things, the newest being 3 back ablations where they burn the nerves in hopes of stopping the back pain so they could then focus on the bladder pain. I wish it worked. Girl. Hey, Heidi, what subtype are you? Do you know what subtype you are? Have you heard of that? Subtyping or phenotyping? Thank you, Ann. Ann says you're my hero. Thank you, hun. I try. I try. You guys, oh, you guys, guess what? I had help this week. For the first time in 7 years, I had help caring for my parents on Tuesday, Wednesday, and Thursday. Oh my God. You have no idea. Oh, it was just heavenly to be able to know that someone else could be there and help them to the bathroom and stuff. So thank you, thank you, thank you for all your prayers, because I found somebody who's really, really good. Okay, so again, Heidi on Facebook, what is your phenotype? Do you know? Do you even know what phenotypes are? If you don't, I can explain it to you. Ashley says, you were accepted into the Ohio clinical study, but I was cut this morning because my labs came back as the least favorable of the 7 women there. It was awesome to pass the in-clinic screening and then be chosen to be in the study. I was so excited for the opportunity to get some relief. And the $20,000 was to give me the money I needed to buy a car for my dad. You know, honey, you just hold on. Hold on, because you never know. You're on the list. You're on the list. So just hang tight, hon. Just hang tight. So the good news is you absolutely qualified. So that's great. So the thing is sometimes patients drop out. And if they do, guess who they're going to call? You. And there's going to be more, with this specific study, there's going to be more coming. Okay. So just hold tight. All right, now you guys, you got to give me questions. Anybody have any questions that I can help you with? I would tell you what I am working on right now in the spare hours. I mean, I feel like I don't get anything done during the day in a way, because I can't get to my content. I can't get to my projects a lot of times because I'm on the phone, but I love being on the phone with you guys. I do. And so don't interpret this as me saying don't call me. Please call. My challenge here is that there are so many things that I want to do, and there's only so many hours in the day. So I am working on my master class for IC, and this is a class that's going to be free for everybody. Free. You don't have to pay, and this is a 2023 master class in IC BPS. So I'm very excited about that. And you can see it right here. Every one of those post-its is a video. And so I've just finished the first one. No, I finished one. I finished the first, okay, 1.5. But Loretta says, hello, Loretta. Nice to see you. Does adenomyosis fall into this? That was a beast I lived with, just horrible. Similar symptoms to endometriosis. Finally had a total hysterectomy. I think so, hon. I think so. I do think so. You know, I think we have to be really honest here and just understand that a lot of the research that women have needed. So you guys, adenomyosis is where endometrial tissue, it doesn't just go up into the fallopian tubes, it actually starts to burrow into the wall of the uterus. And obviously it can make the uterus much bigger, lead to heavy bleeding and all that other stuff like that. Yeah. One of our great challenges here is that up until about 20 years ago, I'm going to say most of the research funded by the National Institutes of Health used men. And it's been a real labor to, I mean, think about how few female urologists there are. That's a kind of a reflection of, I don't know if favoritism is the right word or bias is the right word, but some of the flaws of some of the early studies is they didn't include women in the study. And so there's this whole area of research now that has been building up steam and getting a lot more attention, like the whole research with estrogen and is estrogen safe versus not safe and all that sort of stuff. But I think that we were finally at a point where women's health was being equalized and recognized. And now we have taken a tremendous step backwards with what's happened in the last year. And it is very important that we as women stand up and be counted. We must demand our right to health care. We must demand research into women's condition. We must demand advocates. We must have a seat at the table. Men should not be making decisions about women's bodies. Women should be making decisions. And I mean at the national level and international level. And I'm not being political here. I'm really not. I'm saying if we're going to make a decision about women's health care, women should be on the panel that discusses that, right? And as an example, I am on the male pelvic pain committee as a patient advocate, where we're creating we're creating whole new standards and guidelines for men with pelvic pain. And I will tell you that it's probably 50-50 men versus women. In the old days, it was like 90% men, 1 woman. So we got to get it up there. Women have to be a part of these decisions. We just do. Otherwise, we're not going to get the research we need. It's the reality. It's absolutely the reality. Loretta says, thanks. It was in the muscle, and I always felt it was tied to my bladder. Intense suffering. It just isn't talked about as much as endo. How far can it travel? Any idea? Yeah, endometriosis has been found up at the heart. I just saw okay, I swear, like in the last 10 days, a video of endometriosis in the lungs. In the lungs. It's amazing how far this tissue can travel. It's absolutely amazing. Allison says, thank you for allowing me to visit. Of course, Allison, we're here just for you. I'm new to IC and doctors suspect that's causing my symptoms. February and March, I had, quote, UTIs that weren't UTIs. I'm researching and scaring myself. I've increased my water take. I'm food journaling, and I'm tracking my symptoms. My doctor seems to think to try this for a few months and see if I can find a pattern of what helps. If not, I'll be referred to a specialist for testing. What's your take on pelvic floor therapy? I've had 3 large babies, and I'm sure I could benefit from it, but I just stumbled across that yesterday. Okay, Allison, girl, you are exactly why I do these meetings. So number 1, welcome. You are absolutely not alone. No shame, no blame. Your symptoms are real. When you come to a support group like this, and especially if you drop into some of the IC groups on Facebook, there is a significant challenge, and that is that we're not all the same. For some people, IC begins in childhood. For others, IC begins after menopause. Are they biologically the same? No, they're not. For some people, IC begins after chemotherapy because they have a chemical injury of the bladder wall, or for others, IC begins after having a baby or falling on their tailbone. Are they biologically the same? They are not. IC is a grab bag diagnosis. It means that you've got frequency, urgency, pressure, pain, but they don't know why. They just don't know why. Now, in the old days, we all thought that this was, some sort of incurable bladder disease. That's what we all thought. But now, if you look at our new national guidelines say, you know what? There's no bladder disease process happening in the vast majority of our bladders. There's not. I had a normal bladder. Many of you, if not most of you, have normal bladders. The IC is really a neuromuscular disorder. The only people who have an active disease process in their bladder are patients with Hunner's lesions. These are wounds on their bladder, or patients with a UTI. And I'm not just talking bacterial UTI. We want to talk about fungal UTIs and viral UTIs, right? So we're long past the days of saying, hey, here, you got this incurable bladder disease. Here's a diet. Here's some Elmeron. I'll see you in 6 months. We know that doesn't work. And we don't want to condemn somebody to being on ineffective therapies. It's very important to differentiate between cause versus effect. The symptoms are your effect. You could chase your symptoms for years with treatments. We don't want to do that. We want to find underlying causation. What is the structural abnormality that's causing these symptoms in the first place? So you can't put apples, oranges, and bananas in the same group and expect the same results. And that's why support groups right now are scary, because you might be reading messages from somebody with severe Hunner's lesions, which could be a viral infection, versus somebody who has severe estrogen atrophy versus somebody who's going through chemotherapy. It's irrelevant. It's not helpful. We first have to try to figure out what is your phenotype or subtype. We call this precision medicine. Rather than throwing the same treatment at everybody, we want to understand underlying causation first. And then we want to give you the treatment for your specific cause of IC. So good doctors now, top doctors in the world now, are doing something called phenotyping. That means we're going to spend a little bit of time trying to figure out what underlying causation is. I use a system that was created 7 years ago, in which I was created by the IC researcher at Stanford University, Dr. Christopher Payne. He believes that there are 5 core variants, but in his proposal, he said there are probably more. We just haven't defined them yet. So I'm going to go over the 5 with you now, but just know that we now have a proposal for 9 variants of IC that came from Canada, Dr. Curtis Nickel, one of the top IC doctors in the world. So let's do the 5, okay? Phenotype number 1 is Hunner's lesions. These patients have big bloody wounds on their bladder. And you know, I have pictures. Let me grab my pictures here real quick. So roughly 5 to 10% of IC patients have Hunner's lesions. Ooh, I love that picture, but we won't talk about that picture today. All right, I'm going to leave that one here. Okay, so these are lesions. You see the center point? And there are arms that kind of spread from out that center point. Let me see if I can find a better picture. Okay, see this one right here? So we have a center, and then we've got arms radiating from that. See that? So this is not in everybody. There's a good one right there. There's a good one. Let me see. So the red ones are very, very inflamed. The white ones, the inflammation is gone. Okay. So what is inflammation? See, when you biopsy a Hunner's lesion, it's filled with inflammation. Inflammation is it's basically a biological war. It means your body is fighting something. There's a massive war happening in the center of these lesions. And now we have a clue as to what that war could be, because researchers in Europe found a virus in the urine of patients with Hunner's lesions. So now we know why patients with Hunner's lesions never responded to Elmeron, because for many of them, it could be a simple viral infection. It could be Epstein-Barr. It could be polyoma BK. It could be polyoma JC. Viral infections happen in the bladder. Normally, for example, the polyoma infection is part of the normal human biome. It is not normally active. It gets turned on in patients who are immune compromised. So patients who are going through kidney transplant and who are on immune suppression drugs, that allows the virus to turn on. And when it turns on, it causes what we call hemorrhagic cystitis, wounds in the bladder that bleed. So there are now new efforts to come up with some new therapies for Hunner's lesions, but Hunner's lesions require lesion-specific therapy. They can inject a steroid into the middle of the lesion to try to reduce some of that inflammation. They can cauterize the lesion. And now we know hyperbaric oxygen therapy is also really helpful for lesions. Now, important to say that the American researchers did their own viral study, which confirmed that, yes, roughly 5% of IC patients had active polyoma in their urine. Blows your mind, right? Okay, so more on that to come. The other theory about a lesion is that a nerve that is very, very inflamed. An inflamed nerve is a nerve that releases irritating substances called substance P. Substance P is very damaging to tissue. So if we have a compressed nerve, if we've got very inflamed nerves, that's something to consider. Our second subtype or phenotype is bladder wall driven. So these are patients where there is a legitimate bladder wall dysfunction happening, but there are different things that we have to look for. So the first thing we're going to look for is a chemical injury. A chemical injury. Hold that thought, Elke. For patients who develop symptoms after chemotherapy, the chemicals of chemo are damaging to the bladder wall. Or if you drink way too much diet soda. In fact, oh my God, I had another patient struggling with symptoms confess that she drank Diet Pepsi every day. Diet soda is damaging to the bladder because NutraSweet is metabolized into formic acid and formaldehyde. So we got to lose the chemical irritants of the bladder. So our therapeutic priority for the chemo patient is to figure out what the irritant is and then give the bladder time to heal. And if for patients going through active chemotherapy, there's a drug called Mesnex, which can turn off the irritating chemical. The bladder irritation comes from the metabolite. It's a metabolite of one of the chemotherapeutic agents. So we have a drug called Mesnex that will break it up even further so it doesn't irritate. Okay, our second thing we look for bladder wall irritation is estrogen levels, estrogen atrophy. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. How can the bladder hold ammonia for hours at a time and not get damaged? Well, it turns out your bladder's like your mouth. It's a hollow organ covered with a really thick, robust coating of mucus. It's wet on the inside. So in women, your vulva, your vagina, your urethra, your bladder, and your mouth are mucous membrane organs or structures. And that mucus plays an important role. It's a barrier. It protects skin. It makes it difficult for toxins in urine to reach the more fragile cells of the bladder wall, and it makes it difficult for bacteria to reach those cells to infect those cells. Unfortunately, that mighty mucus is estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus and you can get away with stuff. But if you're on birth control, if you're on Lupron, if you've had a hysterectomy, or if you're in your late 30s, 40s, 50s, and your estrogen levels are starting to change, your mucosal barrier is also starting to change. It's starting to get thinner. It's starting to get drier, and it's going to get more sensitive. This is not a disease. There is no disease happening in these women. It is just dryness. And one of my missions for this year is to continue to pound that point over and over and over again. Estrogen atrophy, also known as genitourinary syndrome of menopause, is not an incurable disease. It's not a disease at all. I will get Elke. Your story is very, very important. Give me 5 minutes and we're going to come right back to you. Okay. Okay. So you would think that the bladder wall subtype would be our biggest subtype, but it's not. Our biggest subtype actually is number 3, pelvic floor driven. These are the patients whose symptoms began after some sort of physical trauma, having 3 big babies, falling on your tailbone. If you were an athlete, if you were a bike rider, a horseback rider, if you fell from gymnastics, from skating, if you were a ballerina, a dancer, a football player, a paratrooper, these are all patients that we've worked with. The pelvic floor muscles directly influence bladder behavior. And the problem with, and of course, you have no idea you have a muscle injury. Your first symptom is frequency urgency. You're going, hey, doc, I got a UTI. Doctor goes, okay, let's do some antibiotics. They don't work. You go back to the doctor. Hey, you know what? Let's just do long-term antibiotics. Now you do antibiotics for 6 months. Doesn't work. And for men can be on antibiotics for years. It's crazy how men are treated sometimes. Eventually, the doctor is going to go, well, maybe you've got overactive bladder. And they give you ditropan, Detrol, Myrbetriq for frequency urgency, but it doesn't work. And eventually, you get the, hey, I hate to break it to you, I think you've got this incurable bladder disease called interstitial cystitis. Here's some Elmeron. Here's the diet. I'll see you in 6 months. And you legitimately want to get better. So you do everything they tell you to do. You follow the diet. You take the meds. 1 year, 5 years, 10 years, 15 years, 20 years, but you're not better. You're still flaring. Why? Because bladder meds do not fix dysfunctional muscles. The problem with dysfunctional muscles is they cause ischemia. If your bladder is supposed to get 24 units of blood a day and it only gets 10, are you going to have a healthy bladder wall? No, you will not. Our therapeutic priority for pelvic floor injury patients is to restore blood supply. How do we do that? With pelvic floor physical therapy. And of the more than $100 million have been put into developing new treatments for IC, every single bladder therapy failed. The only study from our National Institutes of Health, which drives the great majority of IC research here in the United States, the only study that was successful was the pelvic floor physical therapy. And it wasn't just successful, it was massively, spectacularly successful. And when that study came out, the IC world was turned on its head, because up to that point, we're going, oh my God, this is a bladder disease. When no, oh, wait, what? Physical therapy helped? Uh-oh. Maybe this isn't just a bladder disease. Maybe for some people, this is a muscle issue. Now we know that 85% of IC patients have messed up muscles. I had messed up muscles. My symptoms started in 7th grade, the year I broke my tailbone. Of course, we didn't know about that connection until I was in my 40s. Bladder therapies never worked for me. You know what worked for me and got me better? Pelvic floor physical therapy. And now I know when I have a flare and that it's going to be a muscle flare. I don't think I've ever had a bladder wall flare. Well, I haven't, at least in 25 years. But I screw my muscles up all the time. But I know what to do, and that's not bladder therapy. Okay, IC phenotype or subtype number 4 is pudendal neuralgia. These are patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts, or when they bend over, it hurts. Or they might have sciatica. They might have pins and needles. They might have a burning sensation. They might have areas of numbness. These are patients who have a nerve that's being compromised, usually by a tight muscle. So anytime your symptoms are movement driven, that's not your bladder, that's muscle and nerve. And so our therapeutic priority for this group of patients is to figure out which nerve is compressed, release the compression, and restore muscle health and calm nerves down. Again, with physical therapy and maybe some nerve blocks, maybe some nerve calming medications like PEA or gabapentin, maybe even some topical lidocaine to numb the nerves on the skin. And the last but not least, in this subtyping system, we have widespread pain. Why do some patients have multiple pain conditions? IC, IBS, vulvodynia, TMJ, migraines, fibromyalgia. There's about 12 pain-related conditions that are known to coexist in patients. And this is a really significant group of patients. And this is also one of my subtypes. I'm muscle-driven and widespread pain. Why? Well, now we know why. It's the equivalent of a central nervous system injury. And what the research studies show is for patients who struggle with multiple pain conditions, that literally their brain is stuck in a state of fight or flight. 24 hours a day, 7 days a week, that brain thinks your life is at stake. Now, why does that happen? Well, what the research shows is that for 80% of the people that this happens to, including in childhood, there is a major physical injury, like being hit by a car, a bad tailbone injury like what I had. That 14 days of pain will put the brain into a constant state of fight or flight, which ends up sensitizing everything, right? And then for the other 20%, there's a history of abuse and bullying. And that was also my complicating factor, because I grew up in a neighborhood with a very violent man, and I was one of his early victims. He was a rapist and a murderer. You know, I did not leave my home without fear from 4th grade through high school. Of course, my brain went into a constant state of fight or flight. And there's a legacy to that. The legacy to that now is that the brain thinks that that's normal. And it's not normal. It's injury. And we know exactly what to do to break that brain out of fight or flight and get some normal functioning again. And that is with good sensory information. And if anybody has any questions about that, I can talk about that later. Okay, so in our new subtyping system, one of the new subtypes is allergenic cystitis. If you have a history of allergies, if they touch your bladder wall with a little instrument and it turns red and gets swollen, that's when we're going to use antihistamines. That's a theory of that. Another subtype is urethral pain. But this is all, everybody's debating it. Everybody's trying to come up with their perfect subtyping system right now. The point here is that we need to understand your anatomy. Now, one of the questions that I ask patients is, when is your pain the worst? Before you pee, while you're peeing, or after you're done peeing? If your pain is worse as your bladder fills with urine and you feel immediately better once you urinate, then that tells me that your bladder wall is involved. But if your pain is worse, not before urination, but after urination, that tells us muscles are involved. And also, an important question that I ask when I work with patients is, where is your pain located? First of all, is it inside of your body, or is it on the skin on the outside? And you'd be amazed by the number of patients who like, oh, nobody's ever asked me that question before. Yeah, it's actually on the outside. That points us usually to estrogen atrophy. If the pain is on the inside, then the next question is, okay, where? Is it by your rectum? Is it in your vagina? Is it in your urethra? Or is it deeper in your bladder? And again, a lot of people are like, oh, I never really thought about it that way. And for a lot of you, you point immediately to vaginal pain, not bladder pain, which again points us back a bit to estrogen atrophy. But most importantly, if there is a line from your belly button straight down between your legs, a center point, the question I ask is your pain centered, or is it to the left or right of center? Because if your pain is to the left or the right, then it's your muscles. It's your muscles or another structure, maybe a fibroid tumor, something like that. And so it's always interesting. There are patients who go, oh, yeah, it's always on the left side. Okay, well, that's not your bladder. Oh, really? Yeah, no, that's not your bladder. Your bladder is centered. Michelle here on YouTube says, fight or flight, that's me. I was in a car accident at the age of 15. I'm 56 now, and I've never been the same. I feel heard for the first time now. Michelle, honey, oh, big giant hug to you. You are so not alone. And you would be amazed at the number of patients that I have worked with over the years who have walked in your shoes, hon. You suffered a terrific accident. and you know, bones get broken, muscles get torn, but bones normally heal, muscles normally heal. But what we don't really talk a lot about is what happens to the nerves in the area where you were injured. Well, an injured nerve becomes a sensitive nerve. So think about those old timers who, well, not even old timers, but who start rubbing their knee and they go, "Oh, knee hurts, storm must be coming in." Why? Well, the nerves by their knee are sensitive because at some point in time they had a knee injury. And so injured nerves can be sensitive throughout the body. And sometimes, again, when I started this meeting, we talked about local, an injury that begins here that can then affect regional area, the arm, can reach the spinal cord, and eventually can get to the brain. This is not mental illness in any way, shape, or form. This is injury. This is trauma. And we know exactly what to do about it. And there's a very happy ending. And if you ever want to, and this is about proving to your brain that you're safe. And you can't think yourself out of this. Is not, you can't use thoughts to get yourself out of fight or flight. You have to prove to yourself, prove to your brain that you're safe. And we do that with a sensory mindfulness exercise. I can turn off fight or flight in you in 3 minutes if you give me 3 minutes. But let's not do that now. We can do that towards the end of the meeting. So the fact that you have been in fight or flight, girl, I've been there, but I'm not there now. And I would be happy to teach you how to do that too. No shame, no blame. Honey, you just got hurt. You just got hurt. Now, I want to go to Elke here for a moment. Elke said, please pass the news. Sometimes it's IC plus something serious. My primary care provider, my gynecologist, and my urogynecologist blew off my abdominal pain. CTs missed that she actually had endometrial cancer, which is actually, Elke, why I had my hysterectomy 7 years ago. You avoided the recommendation for a few rounds of targeted radiation because it'll kill my bladder. Only changed lifespan by 10%, not estrogen driven stage 1. Oh, thank God it's not estrogen driven. That's fantastic. Did they do a hysterectomy? They caught mine right at the right time too, so I did not have to have radiation or chemo myself. Life, right? It's just so complicated. Yes. When did you have your hysterectomy, Elke? When did that happen? So, Allison, getting back to you as a newly diagnosed patient, I hope that helps a little bit. And if you ever want to talk, you can call the IC Network. You see my phone number in the back. We are a small business of 4 employees, and actually 5. Well, 4.5. Well, really 5. Well, anyway, we're small, but this is what we do all day. Is we usually try to work with patients, be educators. We have books. We have our wonderful book, IC 101. Here it is. This is the best book on the market right now because it is the only book that is talking about all the new subtyping. So IC 101 is not just a bladder disease. I would really recommend that you get this because it will walk you through a lot of this. Again, you've got to really be focusing on cause versus effect. Don't chase the symptoms. You're always working with your doctor first to try to understand your anatomy. You are an anatomical mystery to be solved. Kayleen says, I don't know what pelvic wand is best for me. I thought me and my physical therapist were back on good terms, but she was so monotone on Tuesday. She's still upset that I'm not doing internal work on my own. When she was doing the internal work, she moved up from the vaginal opening, and without consent, I felt her flop the, oh. Oh, well, Kayleen, number one, physical therapists have good days and bad days too. We all have life. Some days are good, some days are not good. Some days we can talk and be supportive. Other days, for all we know, they're dealing with somebody who's, maybe dying in their family. Hi, Gammy. Um, and so you just give her a little bit of grace, hon. Give her a little bit of grace, because we don't know what's going on with her. But the point is that she is working with you, and it is your body. You create the limits. So you just communicate with her and say, not there. But accidents happen, and they do have to touch around there. So I'm not surprised that she went there. I'm not surprised. Hi, Boria. Loretta says, after hysterectomy, doctors dismiss the adenomyosis. It's all gone, according to them. I've never been convinced and have no idea how to have it investigated fully. Well, girl, if your uterus is gone, it's gone. The question is there any endometriosis remaining in your abdominal cavity? That's always a possibility. Laura says, how can I arrange a consult with you? Laura, you can just call that number, or you can pop me an email, icnetwork@mac.com. I operate on a first come, first serve schedule. I start taking phone calls usually around noon Pacific time, and I will go all the way up to around 6 or 7 Pacific time. So you can just call the 800 number and go to the patient education line and leave your name and number. The patients who get priority are the patients who sign up for wellness coaching. So wellness coach. And I'm going to say it's like 50-50, like 50% of the coaching I do, patients who pay for it, and about 50% of it's completely free, and you just wait until I can call you back. So just go to icnetwork.org. Your choice. Your choice. Janet said, I've had a colon resection, motility issues, IC off and on for decades, degeneration, arthritic spine problems, severe allergies. Now I have significant tailbone pain. I've lost over 40 pounds over a few years. I've been to several MTHS of pelvic pain. I've been to several months of pelvic physical therapy for these issues. I can't figure out what type of IC I have, if these other problems are related. They're all related, hon, because in the end, they're all going to involve nerves and muscles. Every surgery you have is going to irritate nerves in the area. Muscles are going to get tight from pain. And then, you've got arthritis in your spine, which means you might not be moving correctly. You might be limping a little bit, which is going to put extra pressure on certain joints and muscles and stuff. So you have to assume that they're all pretty much linked. The question is, what did the physical therapist find, Janet, when you went to physical therapy? Do you have tight muscles? And more importantly, when they start working with these muscles, are the muscles getting better, or are they always locking back down into tension a week later, a month later? If the muscles are always going back into tight tension, then we got to step back from the muscles and start looking at bones. So why are my pelvic floor muscles always tight on my left side? Because I have a bonky SI joint, an old injury. My SI joint, it moves when it's not supposed to move. And so my muscles are locked down tight to stabilize it. And let me get my model here. Let's see here. Model. All right, there it is. So enter the pelvis, right? Okay. So as Dr. Jerome Weiss says in his book, Breaking Through Chronic Pelvic Pain, Western medicine fails the typical pelvic pain patient because doctors play in their sandbox. They don't look at relationships. Urologists stay in the urinary tract, gynecologists stay in the reproductive tract, gastroenterologists stay in the bowel, et cetera, et cetera. And they don't necessarily look at relationships. And pelvic pain is all about relationships. If the bladder, if you're having endometriosis and very, very painful periods, if you've got a UTI, your muscles will get tight to protect you from that pain. organs change the way muscles behave. But the question is can muscles change the way organs behave? That is called the somatovisceral reflex, or the, somatovisceral reflex. If the muscles are funky, they're going to start affecting nerves. They're going to start squeezing nerves. They're going to start reducing blood supply and causing problems. But ultimately, in the end, the other thing that's going on in the pelvis is we've got major skeletal muscles. And here are your major skeletal muscles. These are the muscles that help you open and close your legs. Actually, interestingly, I want you to look at your tailbone here. So here's the tailbone. And you will notice the tailbone tucks under. Think about a dog or a cat with their tails. Their tails are dropped and slightly under. Ours are too. But look at everything that attaches to the tailbone. Do you see that? Whoops, hold on. Look at everything that attaches to the tailbone. So if your tailbone has been broken and now it's sticking out at an angle, or it's sticking out instead of under, these muscles are going to be jacked up. These muscles are going to be messed up. That's why tailbone injuries, coccyx injuries, are very, very common in the pelvic pain group. So the challenge with these muscles, of course, is that you can't reach them from the outside. I had somebody, by the way, if you go to a physical therapist who tells you to do Kegels, they're not trained. The last thing we want to do is Kegels. Kegels are about tightening weak muscles. For us, our muscles are usually too tight. And the last thing we want to do is tighten them. Instead, the physical therapist is supposed to use their finger on these muscles. You see this? That with a finger, you can actually get to these muscles and you can get them to relax and break out of tension. It takes me about 3 to 4 minutes when my muscles get super tight to do that now. And Kayleen was asking about a wand. So wands are a way, I mean, obviously it's going to be hard for you to use your finger and get very deep, though you can do a little bit, or if you're sitting on the toilet, not much. So there are a couple of different types of wands. This one is called Icy Relief. And this is the one that I use personally. I mean, this is my demo. Obviously, the one I use is in my bedroom right now, right? And so it's not straight. It has a little bit of an arc to it. And the arc can help, it can help you reach a little bit more. See that? See how easy it becomes to actually get into these muscles? You know, and part of this, you have to learn how healthy muscle feels versus tight muscle. Healthy muscle feels like a raw chicken breast. It's soft, it's plain, it doesn't hurt. Tight muscles feel like beef jerky and it's painful. And so you basically find the muscle that's painful and then use your wand along that muscle group, right? And so I'm almost always up here on my piriformis, because that's involved in stabilizing this joint right here. Oh, the other, okay, so you can get these from Desert Harvest Aloe. Desert Harvest bought the company. So Desert Harvest has these now. We don't sell them anymore. They do have a much bigger one for women who have a problem, short arms or a problem with reach. That's a much bigger one. Or if you're a little bit heavier and you need a little bit more length. The one that we sell now is from Soul Source. And this is the perfect compromise because it's actually a little bit longer and it has a little arc to it. And so, look at how easy it is. It's like the perfect compromise between the last ones. So the goal of physical therapy is to get the muscles healthy, but we also don't want you to be dependent on the physical therapist. We want you to have the skills so that when you recognize when your muscles are getting tight, you can lay on your bed and work on those muscles. And again, for me, I just lay on the side of my bed, I put my feet up on the wall, 5 minutes, and then I got the muscles completely out of tension and I'm good to go, baby. And I don't let them build up anymore. I don't let the tension build up anymore. So Janet, I think that you probably have a lot of scar tissue down there, but I also think your muscles off of your tailbone are part of the problem. Artie says, here, hold on. First iced coffee of the year. Iced herbal coffee. Dandy blend. No caffeine, no acid, perfectly bladder friendly. It's in the IC Network shop. All right, hold on a second. Artie says, I've had IC for several years. I have a severe case of Hunner's ulcers. As you know, there's no cure for them. Not necessarily true anymore, Artie. I've been on lots of drugs, but none of them helped with the severe pain. After several months, my doctor put an InterStim device in my upper butt. The first stage was all on the outside, and I had to wear it for 10 days. Now the implant is better, and the implant battery are in. I pee constantly, so my specialist is hoping this will help with that. I'm also taking a compound drug at this time. Do you know of anyone like me? Artie, absolutely. I've worked with so many Hunner's patients in the last 30 years. You are not alone, my dear. And if you come on over to the IC Network website and go into our support forum, there's actually a forum for patients with Hunner's lesions that's been there for years. This is from the days before social networking, before Facebook. We had 200,000 patients a month coming onto our website into our support forum. So you can read a lot of old, you can read hundreds and hundreds of patient stories. Artie, the thing you have to understand now is that we've got new information about Hunner's lesions. One of the very significant pieces of this puzzle has been solved, and that is for some patients, it's a virus. It's a viral infection. And so it's specifically the polyoma BK or Epstein-Barr, even COVID. COVID, we now know, can affect the bladder. Even HPV, a human papillomavirus, can affect the bladder. So based upon that new research, which you can find right on the IC Network website if you just go into that area, it would be reasonable for you to request a viral blood test to see if you've got any active virus going on. Because if you do, they then perhaps could do an antiviral. And then at a minimum, maybe adding a little bit of lysine. Lysine is an amino acid that comes in food. It's used for people who have canker sores. I get canker sores. I use super lysine lip balm when I get a cold sore or a canker sore, and the viral infection is cut in half at least, sometimes more. And so implementing or introducing a little bit of lysine in your daily life, if they do find virus, might be helpful. And then the other, just the other thing to consider is we had a remarkable case study published of a woman with Hunner's lesions. She had severe Hunner's lesions and she had a severe prolapse. And when they went in to repair the prolapse, they made a remarkable discovery that her uterus was facing backwards. Her uterus was facing backwards. So the front of her uterus was facing to the rear of her uterus was facing to the front. Why? Because one of the ligaments was broken. So her uterus was free swinging like this. And she had what we would call a torsion injury or strangulation, where it was just swinging potentially in a circle. Skin was twisting, blood vessels were twisting, nerves were twisting. And when they got everything back to where it was supposed to be, something absolutely remarkable happened. Her Hunner's lesions completely healed. She is considered a complete and total cure. And was just published in a major journal a year and a half ago, maybe a year and 20 months ago. And so she had a condition called posterior fornix syndrome, the fornix is the ligament that was detached, I think. And it turns out posterior fornix syndrome is actually rather common. So that would be something else that I would ask your doctor to screen for. So on our website, let me see if I can, here, hold on a sec. Let me just see if I can pull that up for you, and I'll put the link in there. So hold on. So this isn't me saying this. This is, you know, a lot of doctors are like, well, don't believe everything you hear on the internet. And believe me, I completely support that. This is from a case study that was published in the International Journal of Urology in May of 2021. So 23 months ago. Let me give you this link. There you go. So go check that out. I would absolutely ask to be screened for posterior fornix syndrome also. Janet says, what type of anti-inflammatory supplements are the best? If you look at the Bladder Builder, the Bladder Rest, the Cystoman, those are the supplements that we believe are going to have the best anti-inflammatory effect, provided also with a chondroitin for the bladder wall, if, for example, you are an estrogen atrophy patient. Allison said, Allison asked, how can we do that? Hon, I work with patients every day. Absolutely happy to talk with you. Not an issue. Allison said, do we buy the book from the IC Network? Yes, you can get it from us. You can get it from Amazon. It's still from us, but please buy it from us. You can just go right to the IC Network website, order today. It'll ship out to you tomorrow, and it's not a problem. Kayleen says, I don't know if it's a sexual abuse trauma, but I've been in so much pain since. I'm not sure if I should go with the temperature one or the vibrating one, since I have endometriosis and vulvodynia. I wouldn't do the vibrating one, Kayleen, because I think that has the potential of really irritating your nerves. I would stick, I mean, I think you just need to go really slowly, honey. Diane said I had a hydrodistension and my uro didn't find ulcers, but instead said my bladder is very angry and bleeding. So she cauterized the areas in there. Have you heard of them doing cauterization for that and not just on ulcers or lesions? The hydrodistension was low pressure and volume, which is good, right? Yes. So you had the right hydrodistension. It was low pressure, short duration to minimize trauma on the bladder wall. We don't often hear of doctors performing cauterization on general bladder tissue that's not ulcerated, because anytime you do that, you're going to leave a little bit of scar tissue, because wherever they cauterize it, we've got scar tissue, and now that area of the bladder is not going to expand as well, and that's going to affect capacity over time. But if you were bleeding a lot, it might have been the absolutely right thing to do. Now, what, Diane, we have to figure out is, why is your bladder bleeding and why is your bladder so inflamed? That is our big challenge here. Is it because of estrogen atrophy and your bladder wall can't protect itself? Thus, that 1 cup of coffee a day or soda a day or multivitamin a day is irritating your bladder wall and causing a lot of this irritation? Or is there an infection there that's been missed? Could you have a fungal infection like a candida infection that could also explain some of that? That's where the next generation DNA urine testing is so good. Donna says, can you recommend a good candida cleanse? No. Oh, thank you for the 200 stars, hon. Much appreciated. Guys, if you appreciate these support group meetings, there are a couple of ways you can help. If you're on Facebook, you can leave stars. You can come on over to the IC Network and sign up for our free newsletter so you can get the latest cutting edge news, like all these clinical trial announcements and our newsletter. Or you can become a member and get our magazine, the IC Optimist. And so we have a bunch of different memberships that you can do. But as you can see, I'm a terrible businesswoman because I didn't start I don't push that very often. But do please know that we have bills to pay, and buying stuff from us is really, really helpful, or becoming a member is really, really helpful. That's all I'm going to say. Okay. Gammy says here on YouTube, here, hold on a sec. I'm so glad I found your YouTube channel on February 17th. Pain started out of the blue. You had a CT scan clear, all your analysis clear. Urologist plans to do a cystoscope. So, Gammy, if you're still here, the piece of this puzzle is a pelvic floor assessment. Have you had your muscles checked? And so let me ask you this question. When is your pain the worst? Before you pee or after you're done peeing? If your pain is worse before you pee as your bladder fills with urine, then that's telling me your bladder wall is pretty irritated and we got to figure out why, especially if you're a little bit older and your bladder wall is getting drier. That 1 cup of coffee you might be having could be a part of the problem. So Gammy, how old are you, hun? She says the pain is worse before she pees. So how old are you? And you don't have to give the exact year, just give a decade. Like mid 40s, late 40s, whatever. And and you guys, for those of you on YouTube, you're on slow mode, which means you can only post once every 60 seconds. We do that because bad people come in on YouTube and try to disrupt the meeting. I'm sorry. So when you can, give us your age, okay? Donna, getting back to you with candida cleanses. So the problem with it, the problem with cleanses is that they're disruptive to the biome. Whether it's a bowel cleanse or a candida cleanse, as Dr. Jen Gunter says in her book, The Vagina Bible, cleansing protocols are actually far more damaging than you might realize. The thing about candida is there's always going to be fungus in our body. And fungus grows with sugar, with carbs. And so the best way to focus on candida is to restrict your intake of carbs. There's a fabulous book called what's it called? Oh, it used to be right there. And then I pulled all those books out. The Yeast Connection. The Yeast Connection. That's the name of it. And then there's another book called The Yeast Connection in Women. So I had a Candida glabrata drug-resistant infection for 2 years. And it happened after I took amoxicillin and Augmentin for about 6 months, because back then we all thought this was chronic embedded infection. And I got the epitome of the worst thing that can happen. And that is I got a super drug-resistant yeast infection. And it was a beast to kill. And so I did diflucan, I did nystatin. They painted my vagina with gentian violet many times. And in the end, my take home from that was, and if you look at a lot of the recent news right now, drug-resistant candida infections are becoming far more severe, and they're killing more people in hospitals now. So we got to be on top of this. My candida flared if I ate anything with milk sugar. If I ate ice cream, bam, I can guarantee you 12 hours later, actually maybe sooner than that, 6 hours later, I would be in agony. And fungal infections in the bladder are much more painful than typical IC. It is like having hot pokers up there. I was the case study for a yeast infection at my local Kaiser hospital. I saw every OBGYN at the facility many times, because I would go in every 2 weeks as it flared. And I had one doctor yell at me and say, a woman, she said, "There's no way you have candida. None." I said, "Prove it. Do a swab." She was really mean. And she did the swab. She took it out, looked under a microscope, came back in, very hangdog, and went, "I'm so sorry, you have yeast." And I'm like, "I know. Believe me, I don't enjoy being here." in the end, I had to stop all dairy. I had to stop all carbs, no pasta, nothing. I had to starve it. And then we did week-long courses of diflucan. Eventually, we were able to kill all of the yeast inside my body, but there was one reservoir we missed, and that was on my vulva, outside of my body. And I felt like I was having an ovarian cyst had ruptured, go down to the urgent care. They do the sonogram. Nope. Then he looks at my skin down there and he gasps and he goes, "Oh my God, I can see the yeast. I can see it burrowed in on your skin." And I'm like, okay. I mean, obviously it was bad. And then he said, "Didn't you use the nystatin cream we gave you with the diflucan?" And I said, "No, I thought the diflucan killed everything." And he educated me and he said, "No, diflucan does not get into your skin, like on your vulva, in enough quantity and concentration to kill the yeast burrowed into your skin. And that's why we always give you a topical nystatin cream to use with the diflucan." And once I started using nystatin cream, the yeast finally died. Okay. But in the end, cleansing procedures, whether it's bowel or candida with strong herbs, you got to be really careful with, because we don't want to destroy your biome. Okay, so getting back here to Gammy. Gammy is 63 years old. Her symptoms started in February. So Gammy, I'm 62. I will be 63 in July. So here's the deal, hon. You are in estrogen atrophy. You are in estrogen atrophy. That is going to affect your vulva, your vagina, your urethra, and your bladder. They are getting dry. And a dry bladder is as painful as a dry mouth. With a dry bladder, that reduction in mucus in there, irritants from your urine are now going to penetrate into the cells, onto the nerves, and trigger pain. And so the foods that you enjoyed in your 40s, and maybe even your 50s, all of a sudden in your 60s, they hurt like hell. And that's not a disease. It just means your skin is dry. So you need to have somebody look at your skin and do an examination, because it's very obvious. Let's see if you have significant estrogen atrophy, which I'm sure you do. They would then give you some topical estrogen. Think about what happens when you put a dried raisin in water. It plumps up. Well, when you put estrogen, topical estrogen on your skin down there, the cells plump up and they start producing mucus. If you ever notice your urine feels hot as you're peeing, like it's burning you on your vulva, that's estrogen atrophy on your vulva. So this is called the genitourinary syndrome of menopause, GSM. Google it. That's probably what's going on there, hon. I'm assuming they've ruled everything else out. So look at the symptoms of GSM. The treatment is topical estrogen, and then maybe doing something that will have a bit of a coating effect. Now, in the old days, that was Elmeron. But Elmeron's now been linked to eye issues and retinal damage and even blindness. So most patients who are struggling with a vulnerable bladder wall are going to do a supplement that contains chondroitin. And that's going to be, I think I put them all back up here. Hold on. All right. So bladder rest is kind of a starter formula. It's a very simple chondroitin formula for people who tend to be a little bit more sensitive, because any supplement, no matter what it is, has the potential of maybe causing a stomach ache. And so we always start slow with one capsule, see if your body tolerates it. And you can slowly work your way up or down, whatever works. Cystomend is the strongest chondroitin formula on the market. So many patients who transitioned off of Elmeron have gone to Cystomend very successfully. But the best supplement on the market, in my opinion, is Bladder Builder. And the reason why I say that is because it has more methods of action. So it's got chondroitin for the bladder wall, just like these. It's got quercetin for the antihistaminic, just like this. But it has some beneficial amino acids. It's got some probiotics in it for the gut. And most importantly, it has an ingredient that calms nerves down called PEA, palmitoyl ethanolamide. We had a research study in 2019 showing that IC patients responded beautifully to PEA. So PE supplements containing PEA are really the future. It's the most exciting thing that is going on right now in supplementation. Okay. Now, aloe has been around for a long time, and just like aloe can be soothing to a sunburn, aloe can be soothing to the bladder, as long as you're tolerant of it. Some people are intolerant to aloe, but it's not. It doesn't have a what I call a constructive effect, because the human body is not made of aloe. The human body is made of animal material, and chondroitin is a building block of the bladder wall. That's why we prefer chondroitin products over aloe products. That said, if you're in a wicked flare and you just want to soothe things, the aloe that we suggest now is called Aloe Path. And it's a combination of organic anthraquinone-free aloe with PEA to calm the nerves down. So we've got a lot of patients who are using this now for flares, and they're really happy with it. So it's just about, I mean, the blessing here is, unlike when I was diagnosed 30 years ago, we had nothing. We had nothing other than pain meds. I mean, Elmeron hadn't even been approved. All we had back then was DMSO. So the blessing now is we've got some supplements that were originally created by IC researchers, and now got some very motivated companies who are really working to try to understand the hows and whys of pain and trying to give some comfort. And so I think that these are some of the best supplements on the market now. Phyllis says, Bladder Builder works great for me. Love it, Phyllis. Anne says she's got the yeast problem. Absolutely. So annoying. I hate the yeast problem. Danielle says vaginal estrogen helps a great deal for me. If you look it up, it says it also helps with overactive bladder symptoms. Speaking my, yeah, absolutely. Danielle, absolutely, hon, because, you know, think about it. The reason why you have the symptoms of frequency urgency for overactive bladder or interstitial cystitis is because the nerves in the bladder wall are irritated, specifically the alpha afferent nerves. Why are they so easily irritatable? Because of estrogen atrophy. That nice thick coating has gotten thinner and thinner and thinner. Thus, it's easier for them to get irritated. But when you give that skin estrogen, it starts to produce that mucus. So you now have a nice thick coating in your bladder. That's a win all the way around, total win all the way around. So I'm really glad you're doing that. So Janet says, my physical therapist suggested D-mannose for IC. No, that's D-mannose. D-mannose's only job, the only thing it's known to do, let me back up. Mannose is a sugar like glucose, sucrose, fructose, mannose. The human body does not use mannose at all. As soon as you put it in your body, it is immediately excreted into your urine. And the mannose molecule matches a receptor on E. coli. And so the mannose attaches to any E. coli that's free floating in your urine. And once they're attached, you can't separate them. That's when you pee out the E. coli. So the only thing that mannose does is it helps your body eliminate E. coli. It is not soothing to the bladder wall at all. There's nothing in it that would do that. So is it going to hurt? No, because the human body does not use mannose. There is absolutely a group of women who do get recurring UTIs, and it's related directly to estrogen atrophy. So, and I attended a lecture on this years ago at the National Institutes of Health. A lot of research has been done on these women who get recurring UTI. And what they found in that research is about 24 hours before the bacteria arrives in the bladder, it is living in the vagina. So this then led the researchers to ask, well, what's happened to my vaginal defenses? Why has my vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. And so this is why women who get recurring UTIs, but in addition to them giving you an antibiotic, they usually also give you a prescription for topical estrogen to use vaginally to rebuild your vaginal defenses so it does not become a safe haven for bacteria. A little factoid. Isn't it funny how your brain remembers these factoids? And yet, like I was struggling to remember something really simple. I mean, it took me like 2 minutes to remember something that should have been like right there. The joys of getting just a wee bit older, huh? Okay. Gammy says, so gyno, no ovaries, uterus for 20 years, use Premarin cream. Okay, so Gammy, you're never going to have a 20-year-old bladder. You can't, you'll never get back to those estrogen levels, even with the Premarin cream. And so doing something that will protect your bladder makes total sense, like one of these supplements, like Bladder Builder or Cystitis. But diet modification is going to be really important for you right now because your bladder can't defend itself. You've been in estrogen atrophy for 20 years. Okay. And so you shouldn't be drinking any coffee, any decaf tea, any black tea, any green tea. Green tea is devastating to the bladder. No soda. If you're going to do a soda, make it a caffeine-free root beer on ice. But you know, even then, I wouldn't want you to do anything like that for 2 to 3 months. We got to give the bladder plenty of time to heal. The bladder is the slowest healing organ in the body. Nothing happens overnight. It takes time. It takes 2 weeks for one cell to be replaced. And the problem is those stem cells that are trying to go in and fix any holes in your bladder wall are exquisitely vulnerable to acid. So literally 1 cup of coffee will destroy the next generation of cells in your bladder. And they said that at the conference. And that's why the patients who suffer the most, really by far, are the patients who say, I'm not going to let IC rob me of what I love. I'm going to drink my coffee. Without understanding that they're literally preventing their bladder from repairing itself. So ideally, what we'd like is for you to be off of all the irritants for a good 3 to 4 to 5 months. Give your bladder lots of time to calm down. I would be drinking, if you want something that's like coffee, I would do Dandy Blend herbal coffee. That's not going to hurt your bladder. That's what this is. Works like a charm. So give your bladder a break, give it time to heal, and then you want to do the coffee challenge, the IC Network coffee challenge. So how do we do this? If you're flaring, you only do water or chamomile or peppermint tea. That's all you do. If things are calming down, the next thing you try is a rooibos tea, which is a brown grain tea. We have it in the IC Network shop. It's fabulous. If you do okay with rooibos tea, then your next step is going to be an herbal coffee like Dandy Blend or Caffrey Roma or Pero. See how you do with that for a couple of weeks. If you're good with that, then your next step is going to be a real coffee, but a low acid coffee. And so let's see. All right. So we've got Tyler's. And he calls it the world's first acid-free coffee, but Yeah, it's still got a little bit. I mean, at least one low acid coffee paper that I read did find a little bit of acid in this Simpatico low acid coffee. But in my opinion, the best low acid coffee on the market, according to science and according to the patients who we work with, is Bella Rosa. Bella Rosa. And not only so, Bella Rosa has the lowest levels of what's the name of the acid? The acid that's produced when you roast coffee. Coffee acidity is determined in three ways. It's determined by the altitude the coffee bean is grown. If it's lower altitudes, lower acid. Higher altitudes, higher acid. Don't ask me why. Then once it's harvested, the second place the acid is introduced is the way it's roasted. If it's roasted in a big hot metal bin, as most of the commercial coffee is, that contact with metal produces chlorogenic acid. It's called chlorogenic acid. And that's the acid that irritates the bladder so badly. And then the third way the acid is introduced is in how you roast it. So if you roast it, I'm sorry, how you brew it. A hot brew extracts more acid into that cup of coffee. A cold brew extracts less acid into that coffee. Now, what makes Bella Rosa so good is that they created their own roasting process using dry air, and virtually no chlorogenic acid is produced. And UC Davis researchers confirm that. So Bella Rosa, and they also have a half calf. So if you're trying to wean yourself off of caffeine, you can do their half calf, and you can find all of that in the IC Network store. Diane said, how about low acid decaf? Coffee made with alkaline water with steamed milk. Is that not a bladder irritant? Well, Diane, as they said to me in my first chemistry class that I took, organic chemistry class that I took, no, inorganic chemistry. Bleachly, okay, this is a direct quote, so bear with me. The quote was, as we were all wearing our goggles, wearing our lab coats, standing in front of our lab station, the lab instructor said, bleach will eat your eyeballs out just as quickly as sulfuric acid, right? So bleach is alkaline. Acid, sulfuric acid, is acidic. On the pH scale, neutral is 7. Anything higher than a 7 is alkaline. Anything lower than a 7 is acid. So the problem with you making your coffee with alkaline water is you're actually making kind of bleach coffee. I mean, there's no bleach in it, but you're dropping the alkalinity levels. You're raising them too high, and that has the potential of irritating your bladder. Can you just use spring water? Spring water, it has the correct minerals in it so that it's nicely pH balanced. Alkaline water with I don't like that idea at all, Diane. I just don't. I would not do that. Jill says, hi, Jill. It's always nice to meet another Jill. I'm trying the PEA for the first time. I have IC estrogen atrophy. I've been using Ostroderm with good results. My biggest problem was with horrid, unbearable pain with urination, urethral mostly, so that's estrogen atrophy. I don't have frequent urination anymore. Yeah, yes. My naturopath also took blood and says I'm sensitive to peanuts and clams, so eliminating peanut butter gave me immediate relief. Good to know. About the PEA in your shop, because body heat causes more pain in the summer, so it's starting to flare. It's going to be very interesting to see how you do with the PEA, hon. She's referring to Piura, which is just the PEA and the resveratrol. There's nothing else in it, no other chondroitin in it or aloe. It's what I take, and girl, I got to tell you, I love it. My body is so happy. My sensitive nerves are just so much less reactive and less painful. So let's see how you do. Let's see how you do with it. just know that because you have estrogen atrophy, your goal should always be to try to plump up that bladder wall and to try to give your bladder wall a bit of a coating effect. And so, doing something like bladder rest with the Peora or just doing bladder builder by itself, then you don't have to buy the PEA separately, might be interesting. But every woman, as we get older, we have to focus on the quality and health of our skin. And that's not only externally, but internally. So that chondroitin might give you even more benefit. Might. You won't know until you try it. And you guys, please remember, I'm not a doctor. It's not my job to give you medical advice. My job is to educate you, inform you, and then kick you in the butt and get you back to the doctor with a new set of questions, right? I'm trying to share options with you. Open up some new doors, some new windows, give you a little bit of hope, and also get you fighting. I want you to walk into every doctor's appointment strong, confident, chin up, looking them in the eyes. You are a partner in your medical care with your doctor. You are not subservient. In fact, you're really the boss because you pay them, they don't pay you. And I want you to be so knowledgeable that you can walk in and immediately have a productive discussion about your treatment options and what they might have missed, right? And what else you can do. Gammy says, I'm learning. Yes, I'm learning. No coffee for 2 weeks. Been on oxybutynin for 5 weeks. So Gammy, oxybutynin, also known as ditropan, is an antispasmodic. And so if you were having bladder spasms, it would turn off the bladder spasms very, very quickly. The problem with there are a couple of problems with oxybutynin. Side effects, dry mouth, dry eyes. You might notice the longer you use it, the more difficult it becomes to urinate. That's what I think. I took it for about 3 months. I don't remember. I mean, this was back in the 90s. But what I did notice is that the longer I used it, the harder it was becoming to urinate, and I needed to urinate. But more recently, we now know that anticholinergic medication, and ditropan is an anticholinergic, along with amitriptyline, Elavil, and along with hydroxyzine, Vistaril, and Atarax. Anticholinergic medications are now linked to cognitive decline. And I think, if I remember correctly, like in the last couple of years, the 3-year mark, I think, was the big mark, that if you took it every day for 3 years, you had a 50% increase in cognitive decline and dementia. So there has been a very deliberate step away from oxybutynin towards another medication called mirabegron, or the generic name is mirabegron. The product name is Mirbitriq. And let me just spell it for you. It's Myrbetriq. So Mirbitriq is the medication that's now being prescribed for frequency urgency. Okay, and it's not an anticholinergic. Actually works a little bit better than the ditropan and the Detrol, but health insurance companies don't like it because they have to pay more money for it. And so it's really sad that insurance companies, they know the problem with anticholinergics, they know that it can lead to cognitive decline, and yet they are still prescribing it because they don't want to fork out the dough for the safer med. So I would, Cami, if I were you, talk to your doctor about Mirbitriq and the pros and cons of using oxybutynin, because the longer you use it, the greater the risk. Okay, that's well published in many studies. Well published in many studies, especially for older folks. But what was interesting, the first studies were focusing specifically on anticholinergics in the elderly. And then if I remember correctly, somebody did a study of people in their 20s who were using anticholinergics, and they found the same cognitive decline in younger patients also. And I can tell that when I talk with patients over the phone. I can really tell patients who are taking a lot of medications because their cognition is getting slower, their word choice is getting slower, they're kind of hazy, um, distracted isn't the right word. It's that they can't focus to have a conversation, and very easily confused by what's going on with them. And that's all from the overuse of anticholinergic meds. There's some over-the-counter cold meds that are anticholinergic. So we're really trying to be very, very careful about this now. Very, very careful. Because I don't know about you, but now that I am a veteran at taking for very, very elderly parents, I want my cognitive abilities when I'm old. I will fight for my cognitive abilities when I'm old. I would do everything I can not to ever have to take an anticholinergic. I do not want to be, Gammy says, I need my brain. Yeah, man, we all do. I mean, and just the whole thing about getting a little bit older and we start losing a little bit of being able to pull those words quickly, like the chlorogenic acid. It took me about 20 seconds to remember that instead of catching it right away. I think it's sad, that if you're over the age of 50, modern America wants to throw you away. I mean, they do. In jobs, people over 50, they're the ones that are let go. I mean, I can remember I had a family member who's the owner of the company flat out said, get rid of everybody over 50. They're too expensive. Good employees they were firing anyway. They just wanted to bring in younger people who were cheaper. But I feel far more effective now than I ever did before the age of 50. I mean, there is a gift of maturity, but also just being able to pull all these pieces together over time into one cohesive unit. And so I think it's really sad that people are minimized to the degree that they are. Listen, we're tough. And and I say this quite, you guys, for those of you who've known me, when I started the IT Network 30 years ago, I was Miss Academic. We talked about urination and defecation. Very academic. Come on, it's been 30 years, and today it's all about peeing and pooping. Right? I mean, it's just, there's no reason to be, I can be academic when I need to be academic, but we're just talking, right? And I say this in the best way I can possibly say this, without any offense intended. I want you to be tough bitches. I do. I want you to be strong, confident, forceful. This is your body. This is your life. We want to fix this so you can get back to enjoying your day. And that begins with you not giving your power away. It begins with you walking in educated, informed, with a good set of questions. And you can't walk in and say, how can we treat this now? Nothing's working. That's the wrong question. The right question is, what is causing this in the first place? And that's what our AUA guidelines say. If you're not responding to treatment, if you're getting worse rather than better, for God's sake, stop what you're doing, take a step back, revisit the diagnosis. What have we missed? Because clearly, if you're not getting better, they've missed something. And some of you also, especially with, so classic, there are two classic mistakes that IT patients make. Well, three. Number one, diet, for if you got bladder wall issues. Number two, for women who start estrogen therapy and it's really hot, and when they start using it, it burns them. They stop using the estrogen, not understanding that, yeah, dry skin burn. But every time you use the estrogen, the skin gets healthier and healthier and healthier. And so that burn takes, go away in about 10 days as your skin plumps up and gets strong. But there are a lot of women who do. They use estrogen once or twice and they walk away. And it's like, don't do that. I mean, I've worked with some ladies in their 80s whose vulvas are like dry potato chips. And I promise you, they are in agony, absolute agony. We have to work on our skin. The quality and health of our skin matters. Mucous membranes are supposed to be moist. If they're dry, it's going to hurt. And then the other mistake that some patients make is they walk away from physical therapy. They just don't want to do it. They don't want people's hands on their body, much less a finger inside their vagina. And that is a catastrophic mistake. Because if you're muscle driven, there's no other treatment that's going to fix those muscles. And the thing is, as Chris Payne wrote in his proposal for his 5 subtypes, he said, listen, it's unconscionable that we're telling patients that they have an incurable bladder disease. Number one, it's not a disease for the great majority of us. And number two, with the right therapy, it is healable. Muscles respond beautifully to muscle therapy, but you have to be willing to put in the work and do it, right? And that's work. Got to be willing. It sucks. It sucks that it's down there. It'd be so much easier for a broken shoulder. It's embarrassing. It's frustrating. It's uncomfortable. But you and I, we got the injury. For me, it was a broken tailbone. I'm not ashamed of it at all. It happened. I can't change history. Now I know what to do. And that is, I'm going to work on my muscles. And as long as I work on my muscles, I have listen, my IBS is gone. My IC symptoms are gone. My anxiety is gone. So much of it is better just by finding the right treatments and doing some good mind-body medicine. When I talked earlier about IC subtype 5 widespread pain and how do we get the brain out of fight or flight, let's do that exercise now, okay? So if you struggle with anxiety disorder with your symptoms, that's a very, very common. Who wouldn't be anxious? If you're in pain, of course you're anxious. But again, for many of us, it all began not with the bladder symptoms or the end result. The first thing that often happens is either a physical injury or abuse. And the best example I can give you is, let's say that you have a violent parent, an alcoholic parent. School is your safe place. When you went to school, you were safe. But as soon as school gets out, you're going to go into fight or flight. And the closer you get home to school, the scarier it is until you're finally home, and you're just hyper vigilant. You're looking, are you going to say the wrong thing? Is he or she drinking? And this isn't just one time. This is your entire childhood. 20 years or 18 years or 16 years of being afraid of a family member who was drinking and hurt you when they were drinking. My case is exactly the opposite. I have a great home, great parents. What I had was an abuser at school who was my age, who was severely mentally ill, who was hurting lots of people, myself included. And the year that I went away to college, he raped and murdered my neighbor. And when they called me at school, I collapsed. I can still remember the conversation. I'll never forget that conversation. Because I knew it would have been me, and it could have been me. I was one of his many victims. So I did not leave home without fear from 4th grade through high school. And even after that, I mean, I've been on a couple of radio shows, and I literally would call the DA, the district attorney, first. to make sure he wasn't nearby. I was told, the DA told me he was dead. He died in prison, but somebody else told me he's doing life. So we'll see. Anyway, so there's a legacy of that trauma. And the legacy of that trauma is that your mammalian brain, your brainstem, has been taught that your life is at stake every single day. And even though it happened a long time ago, your brainstem's still there. This is normal behavior for them. But we can fix this. We know how to fix this. And I'm going to give you a great technique that will break you out of fight or flight. Okay? So understand the language of fight or flight is your sensory information. This is your sympathetic nervous system, the mammalian center of your brain. There's no cognition happening here. If you looked out the window and saw a saber-toothed tiger, or in my case, a fire coming towards you, the mammalian part of your brain immediately takes charge. And it has one job: to save your life. It turns on the amygdala in your brain. Your amygdala sends out chemical messengers called adrenaline, and it raises your heart rate, it raises your blood pressure, it tightens your muscles to prepare you to fight or flee. Okay? Now, obviously, this was essential in caveman years when there really were saber-toothed tigers. Our body has to have a way to protect itself in the state of life-threatening threats, right? But today, we don't have saber-toothed tigers. We have a lot of other threats in our life, right? But ideally, you would only be in fight or flight maybe 15 minutes once a week when you're driving your car and somebody stops in front of you. Like, okay, heart rate goes up, the threat is gone, heart rate goes down, right? So you see the tiger, the sympathetic nervous system takes over, turns on the amygdala, heart rate goes up, blood pressure goes up, et cetera, muscles get tight. But you're smart now. You shut the door, you call the authorities, they come out and they deal with the tiger or the fire. They anesthetize the tiger, it's gone. They drove it away. Fire department came, fire's out. Threat is gone. At that point in time, the parasympathetic nervous system is supposed to retake control. What does it do? It calms everything out. It lowers your heart rate. It lowers your blood pressure. It relaxes your muscle. So we want to be living in a state of relaxation, parasympathetic relaxation all day, rather than sympathetic fight or flight all day. All right. So how do we get that back to where it's normal with good sensory information? So we're going to do a technique called I Spy. And Diane, I'll get to that question in a quick moment. Okay. We're going to turn your fight or flight off right now. It's really, really easy. It's with sensory information. So we're going to do the I Spy technique. So follow with me here for a moment. Anybody who doesn't want to do it, that's fine. Just read a book. Check your email. Okay. So I want you to take a deep breath with me. In for 3 and out for 3. And let's do it again. One more deep breath. In for 3 and out for 3. Okay, I want you to pick something in your room that you like to look at. So I'm gonna pick this beautiful Afghan that was made for me by my friend Donna, who's an eye seer. So I want you to just take a couple of moments, whether it's a painting, whether it's out the window, whether it's a pet, a child, whatever. Pick something that you like to look at, and let's just look at that for a couple of seconds. Thank you, Donna. Okay, in for 3 and out for 3. Okay. What can you hear right now besides my voice? I want you to stop and take a couple of seconds, and I'm not going to say anything. I want you to listen. Do you hear TV? Do you hear the wind? Do you hear a furnace? Whatever. Just close your eyes and listen to your environment for a couple of seconds. Okay. In for 3 and out for 3. Okay. Now I want you to smell. Are there any fragrances or aromas in your room right now? Do you hear? Can you smell dinner cooking? Is somebody baking something? Can you smell the washer dryer? What can you smell right now? And this is where aromatherapy really helps. I normally have, oh, here it is. I love these Mario Badescu facial sprays. So good. Okay, so close your eyes and just smell your environment. A couple of seconds. Okay. Deep breath in. Deep breath out. Okay, what can you taste right now? Are there any flavors in your mouth? For me, I've got Frappuccino flavor in my mouth. And it's okay if there aren't, but are there any flavors in your mouth right now? Okay, deep breath in. Deep breath out. Now I want you to take your hand and I want you to rub it up and down your leg. I'm wearing soft jeans right now, right? So rub your hand up and down your leg. All we're doing is we're engaging touch receptors in the brain. Okay? Deep breath in. Deep breath out. Okay, now comes the fun part. This is the really fun part, and this is great to do with kids, especially kids who might be a little fearful. If you could look at anything that would put an immediate smile on your face, what would that be? Would it be the ocean? Would it be a waterfall? Would it be a grandchild? Would it be a pet? Would it be a horse? I want you to pick something that you would just love to look at. So I'm picking the beach, the Kahala Beach in Oahu. It's kind of a small, quiet, non-touristy beach. And just visualize in your brain that you're looking at this thing that you would love. Just for a couple of seconds, standing on the beach, the waves are coming in, salt's in the air, seagulls are flying by. But the best part about it is I know I'm away. I'm taking a real break if I'm at the beach. Okay, deep breath in, deep breath out. Okay, what could you smell that would put an immediate smile on your face? What would you just love to smell? And for me, every single time, it's baking cinnamon rolls. If you could smell anything that would put an immediate smile on your face, what would it be? What's your favorite fragrance or aroma? Like coconut. For some of you, it's coffee, and that's fine. No problems with that. Close your eyes and just pick your favorite smell. I love coconut. And Sea and Ski suntan lotion from my childhood, and they started making it again. Anybody remember the old green suntan Sea and Ski sun lotions? It was the option to copper tone. Oh my God, best smell ever. Okay, what could you hear that would put an immediate smile on your face? Would it be the ocean waves? Would it be laughter? Would it be a waterfall? What would you just love to hear? Your favorite music? Kenny Loggins, BPS, my two favorites. Pick something that you would just love to listen to right now. Close your eyes. and visual and imagine it. BTS singing Microcosmos. Love that song. Okay, deep breath in, deep breath out. All right, what could you taste that would put an immediate smile on your face? I don't care if it's IC friendly or not. What is your favorite thing in the world to eat or drink? And for me, every time it's a hot cinnamon roll or hot apple pie. Pick something you love to eat. Close your eyes. Imagine it right there. Oh my God, I just took it out of the oven. It's gooey. Cinnamon rolls have never tasted better than during a pandemic. I love them. And oh my God, that first bite, insane. So good. That's my comfort. Okay. Deep breath in, deep breath out. And last but not least, what could you touch that would put an immediate smile on your face? Would it be warm sand at the ocean? Would it be clean, fresh cotton sheets hot out of the dryer? Would it be a beloved pet? Or my favorite, as a woman I was working with last week said, her husband. I love that. So I want you to close your eyes and I want you to imagine, what could you touch that would put an immediate smile on your face? I'm going to go with warm sand. You're sitting at the beach now. Even if there's a little breeze, the sand is warm. It just feels good. Very grounding, very centering, right? Okay. Deep breath in. Deep breath out. Okay, how do you feel? How do you feel? Yeah, you got a smile on your face? The easiest way to turn off fight or flight is by giving your brain good sensory information. Now, of course, the problem is one of the legacies of abuse and trauma is that we've been stuck in negative thoughts for a very, very long time. You're the no person. Hey, you want to go take a drive? No. You want to go out to eat? No. You want to go to a movie? No. You want to? No. You want? No. And I asked my brain, I asked my doctor, I said, why do I do that? Why does my brain go no every single time? Like literally the CEO of a software company asked me to drive up to Tahoe with him and I said no. Nice guy. It's the last I saw of him, right? So I've asked doctors, why? Why do I say no? And their answer is real simple. You're guarding. You're guarding. Your brain's just guarding you. That's all. The thing is that the trauma happened a long time ago. There's no reason to guard now, right? And so we have to teach our brain how to get out of guarding with the thing like I Spy, good mind body medicine like that. But the other thing we got to deal with is we got to deal with the fact that right now we are swimming in adrenaline. Those no's come from adrenaline. That anxious thoughts are coming from adrenaline. The panic attacks are coming from adrenaline. I used to have panic attacks before I went to the doctor here in this very house, like because my parents were caring for me back then. I mean, I couldn't drive. I could barely function. I couldn't sleep at all. Thank God for my parents. They're the ones who kept me alive back then. So I was having a panic attack before a doctor's appointment. And I just like, all right, come on. I have a master's degree in psychology and I still can't deal with this. But rather than being ashamed, I just like, okay, I need some skills here. I do not know what to do. And I signed up for an anxiety management class that completely changed my life. I have not had a panic attack since I took that class. And the first thing, and of course I had a panic attack going to the class because it was like literally on the same floor as my urologist's office. But I went. And the first thing that happened in the class that was so cool was like literally in the first 5 minutes. Because I saw, as soon as I walked in the door and started chatting with a few other people, I was like, oh, wait. Like we're all just totally normal people that just had something happen to us. So like the people who won the California state lottery, were in my class. They developed anxiety disorder after winning the lotto. So the first thing the class gave me was very, very quick. And it's like, oh my God, Jill, this is a normal thing that happens after trauma. I'm a normal person. I just got hurt. Okay. That takes 90 to 95% of the shame I was feeling away. It's like, okay, got it. The class was created by an orthopedic surgeon with anxiety disorder. And so in the class, they said, listen, we're not here to psychoanalyze you. We're not here to talk about your childhood. We're not going to do any of that. If you want to do that and you need to talk about something, I will make that happen for you. But that's not the purpose of this class. The purpose of this class is to get you out of fight or flight. Because you're living in fight or flight right now, right? And everybody's like, yeah. So how do we do that? Oxygen turns off adrenaline. So every time you have a negative thought, like, no, I can't go to Tahoe, there won't be any bathrooms. Okay. That's putting my brain into fight or flight. That's an immediate shot of adrenaline. Right? And you don't just have one negative thought a day, you have hundreds a day. So you don't just have one shot of adrenaline going through your body, you got 100 going through your body. And it's this massive stew of adrenaline that's driving everything. So driving all the panic, everything, that's coming straight from just this overdose of adrenaline. And that's basically what the instructor said, is you're overdosing on adrenaline right now. Just as you're sensitive to chemicals on the outside, you're sensitive to chemicals on the inside. Right now, you have way too much adrenaline going through your body. So what we're going to do is get you out of the chemical portion of fight or flight. And how do we do that? With oxygen. So he said, though they taught us a 3-step system, works beautifully. I still do it today. I've never had a panic attack since then. So he said, the goal of the first week, we're just going to get you out of fight or flight. So every time you have a negative thought, the first thing I want you to do is visualize a stop sign. Just stop. Just visualize a bright red stop sign. Like, oh, no, there won't be a bathroom. Stop. Then you take a single deep breath in for 3 and out for 3. And that oxygen destroys the adrenaline produced by that negative thought. It's done. It's over. It can never haunt you again. Oxygen turns off adrenaline. So stop sign, deep breath. And then the third thing is you have to remind yourself it's a thought. It has no power. So what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow's going to be the best day of your life. It's just your brain guarding. It has no power at all. Right? So anyway, they sent us on our way, and I had my first negative thought walking out of the room. Oh, it'll never work. What a stupid idea. But I did it. Stop sign, deep breath, minimize the thought. I did that at least 100 times the first day. I was shocked. I was having, like, literally every thought was a negative thought. Every other thought was a negative thought. I was shocked. I'd gotten so used to it, I'd tune it out. The next day, I did it about 50 times. The third day, I did it about 20 times. Took the class on a Monday. By Friday, I only had to do it once. And you know, for the first time since elementary school, I was calm. Mind blown. Because I had gotten rid of all of the fight or flight driving adrenaline in my body. I was calm. It was amazing. Now, the other piece of this puzzle, I hope that you can see from my office, is I'm very deliberate about how I live. I live in a very happy environment. I've got inspiration, everything. My newest one is this. My newest thing is this. It says, your mind is a garden, your thoughts are the seeds. Will you grow flowers or will you grow weeds? I have stuff like this all over my house. I've got love signs. You name it, I've got it. What you can't see over my head is I have a hanging lamp covered with birds and fairies that hangs down about 2 feet. It's like literally right there. So I got to the point where I only had to do, stop sign, deep breath, minimize thought, maybe once every 3 months for years. And it was amazing. Everything went away slowly but steadily. The nervous system calmed down, fight or flight went away, the bowel issues went away, a lot of the bladder issues went away. So much went away, like peace for the first in a long time. But then COVID happened and our firestorms happened because I live in fire country. Now we're prepping. See, I got to do it. Stop sign, deep breath. Jill, you're not caught. You can't predict fire season. It's going to be fine. Okay. See, I caught myself doing it right there. Okay. I got back to the point where I was feeling very anxious every day. And that's okay. Because you know what? I have a system that manages it. And I will never, ever, ever let it get out of control. I have one negative thought. Sometimes I'll let it fly. I have two negative thoughts in a row. Stop sign, deep breath, minimize the thought. I'm very, very deliberate in managing this, and even went through emergency surgery for cancer. I was doing it in the car. Didn't have a panic attack. So I double dog dare you to, for those of you with widespread pain, anxiety disorder, no shame, no blame. This is about a nervous system that has been traumatized. Now we have to tell your nervous system that you're safe and you're not trauma, that there's no active trauma. And we do that with the I Spy technique, good sensory information. We got to nip those negative thoughts in the bud. Affirmations, baby. I can do all things through my faith, which strengthens me. Insert whatever faith you have. Every day in every way, my life will get better and better. Be bold, and mighty forces shall come to thy aid. Have good, positive, encouraging statements you say to yourself. Okay? All right, now hold on. Let me get back here. We have some questions here. Sorry. Hold on a second. Denise says, was using estradiol for vaginal atrophy, had my ovaries removed 10 years ago. For about a year, I did great, just had a UTI, flare, burning pressure. I'm so confused. Is it not working? No, honey, it's working. It just means that with age, you're never going to have a young bladder again. And so your bladder might need a little bit more help than just the estrogen. Keep the estrogen because that's what's going to keep your skin healthy. But maybe incorporating, talking with your doctor, he may want to increase your dose of estrogen, have you use it a little bit more frequently, or maybe begin using something with chondroitin like Bladder Builder or Cystoman, which will help give your bladder a little bit of more coating in there. But the reason why you had a UTI is because you're dry. And with that dryness, it's easier for bacteria to reach the bladder wall and infect the bladder wall. That's why that estrogen is so important. But something that contains chondroitin, again, like Cystoman or Bladder Builder, might give you just a little bit of an extra coating in there to protect it a little bit more. Diane says, is Celexa or citalopram an anticholinergic? I think it is, but let me, I think it is. No, it's not. It is not an anticholinergic. So that's good. So the antidepressants, which are the that are called psychotropic, are benzodiazepines, clonazepam, SSRI. Well, hold on. Now, wait a second. This is completely conflicting information. Hold on. Wait. Hold on. What are the four most common anticholinergic drugs? And oxybutynin, Spiriva, ipratropium, cyclopentolate, and atropine. And of those, it's the oxybutynin, which is the most common. It says it has fewer side effects than older antidepressants. I must go to the National Library of Medicine. Hold on to get the right answer here. All right, hold on. My goodness gracious sakes alive. You'd think you'd find, well, no, it's saying it's an anticholinergic. It might just be a very mild anticholinergic. Good question for your pharmacist or your doctor, okay? They're always, I swear, I just remember that there was a new antidepressant that was approved by the FDA in the last 6 months that was considered much safer. I don't remember the name of it. I would just bring this up with your doctor and say that you're learning a little bit more now about the risks of anticholinergics, and see if there's another medication that you might be able to try that might not have as strong of an anticholinergic activity level. Maybe. I mean, just have a discussion with your doctor. Obviously, it's working for you now. Maybe it's something as simple as lowering the dose, but don't do it on your own. You got to talk to your doctor about it, okay? Sue says, what was the amount of time to be on tea for the coffee challenge? I would say a week. Denise says, thank you, Jill. So blessed to have you. Thank you, hon. How do you prevent flares after sex? Christine, that flare with sex is a muscle flare. So number one, physical therapy. Let's get those muscles nice and relaxed and healthy. It's the tight muscles that are painful with sex. You might be able to do something like a badge. So the thing you got to understand about the sex flares, in a man with pelvic pain, the worst moment is the moment they ejaculate, because that's when they have the strongest muscle spasm. For a woman, it's not. It can be with penetration if the muscles are tight, but generally the flare begins 4 to 6 hours after sex, because that's when the female pelvic floor starts to do some very gentle spasming to help sperm meet egg. And so it's that flare 4 to 6 hours afterwards that's the most annoying for women, myself included. And so what can we do for that? Number one, maybe a vaginal Valium suppository, where you can put Valium up in your vagina that immediately goes to that muscle and helps to relax that muscle. Or you could do an oral, a skeletal muscle relaxant like baclofen, which is non-sedating, which is really good during the day if you're working and driving. Shouldn't be any problems with that. There are some sedating that can cause a little bit of drowsiness, skeletal muscle relaxants like Flexeril. That's what I use at night, but I take a quarter of the lowest dose. I did it last night. I do really well with a very, very, very low dose skeletal muscle relaxant. Not every night, but when my muscles are getting wonky, then especially my TMJ, and I've got ruptured disc in my back right now. And so who knew that a ruptured disc in your back can cause your muscles to get tight? They do. So my thighs have been very tight because I tweaked my S1 again, lifting something again. So what do they want? Muscle relaxants, Flexeril, and Advil. So annoying. And heat, using heat. And also, of course, for women, we really want to make sure you urinate after you have sex. Let's flush any potential bacteria out. Maybe using a peri bottle to rinse your skin off. And there you go. But ultimately it's about muscles and trying to relax those muscles. Skeletal muscle relaxing can work really well for that. All right. Any other questions? Give me some questions, guys. Challenge me. What is the theory of life? I don't know. I find life baffling. What is the purpose of life? I don't know. I'm trying to figure it out. Renee says, so sorry, L5S1 is your issue too. I know, right? So annoying. So annoying. What are some of the most common questions that I get from patients? It's going to be, what's the best treatment? What's the best treatment for IC? We don't, that's the worst question you can ask, because it's about what's the best treatment for my specific case of IC, because we're all different. So for the pelvic floor patient, it's physical therapy. For the Hunner's lesion patient, it's lesion specific therapy. You know, and so it's not about what's the best treatment. It's really what is your phenotype. We need to understand what your unique case of IC is, so we can find the correct treatment for your unique case of IC, right? That's always going to be our goal. Renee says, have you heard that baclofen causes fatty liver? No. Really? Really? That's wonky. Baclofen for the treatment? No. Hold on. Baclofen shows promise in patients with alcohol. Wait. Hold on. You going downstairs? Has mom gone to the bathroom? Huh?
I'll ask.
Okay. My mom is very weak right now. She's back actually in the wheelchair. Baclofen, fatty acid, fatty liver. Let me see. I had an aunt die of fatty liver disease. I lost my cousin a couple of weeks ago. Honey, I'm not seeing anything in it in the National Library of Medicine. So I don't know. I don't think so. Diane says, how do you ask your urologist to test for bladder fungal infections? I don't think she believes in anything but bacterial infections. You know how you do it is you bring in the National Library, you bring in the National Institutes of Health study that proves that some patients with severe bladder pain have fungal infections. And so let me get that for you. Hold on. So new research study finds higher rates of candida rather than bacteria during IC flares. Let me just read this to you guys. One of the biggest challenges that both patients and physicians struggle with are the sudden, often unpredictable flares which occur in most patients. Why do they occur? How do they occur? Are bacteria involved? Are they caused by eating the wrong foods? And over the past 3 decades, patients have shared many stories of flares that have occurred after eating meals, traveling, periods of high stress, and so forth. The MAP Research Network has released new research suggesting that fungal candida may be involved. Let's see. Dr. Curtis Nickel and colleagues have been studying flares for the past couple of years. This month, they released their first study of the microbiota, bacteria and fungi, found in the urine of IC patients. Interestingly, the data did not find significant fluctuations of bacteria during the flares. Here, hold on. Yeah?
She'll be 1 hour, she'll have to go again.
Okay. All right, Dad. Thank you. You okay?
Yeah, I think I'm okay. I'm going to go give it a try.
How's your stomach?
Fine.
Okay, good. Okay. Let me repeat this. Dr. Curtis Nickel and colleagues in the MAP Research Network have been studying flares for the past couple of years. This month, they released their first study on the microbiota found in the urine of IC patients. Interestingly, the data did not find significant fluctuations of bacteria during flares, but it did show higher levels of fungi were found, specifically Candida and Saccharomyces. They determined that, quote, women who reported a flare remained 8 times more likely to have fungi present than those who did not report flares, specifically referring to urine obtained directly from the bladder in a clean catch specimen rather than a normal void. And so I'm going to give you first, if you go to the IC Network website, I have a blog that I wrote about this. And for you guys on Facebook, let me give you that link. And for you guys on YouTube, I can get you the link in a minute. Okay, now specifically, I'm going to give you the link to the paper. And so I would print out this study from the National Library of Medicine and walk in with that. Okay, there's the paper. All right, YouTube, let me get it for you too. You guys, you're on 2 separate computers, 2 separate internets. Facebook is on Comcast. YouTube is on AT&T. All right, so there you go, you guys. Here on YouTube, there's the link to that. And so you can ask for a next generation DNA urine test. All right, YouTube, here is the actual study at the National Library of Medicine. All right, great question. I love this question. Thank you, Sherry. Yeah, she was very deeply ill. So it's a surprise, but it wasn't a surprise. But as we all went, she's not suffering, and that's the most important piece of this puzzle. I wrote in my note to my other cousins, I said, she was met at the pearly gates by my Aunt Shirley with a big giant smile who said, welcome home, we miss you. My Aunt Shirley was lovely. We lost her last year. And then she was met by my Grandma Betty, who brought in a big giant plate of homemade cookies. That's why we called her Cookie Grandma. And then she was met by her mom, who was leading a horse for her to ride in heaven. And that's the way I'm going to remember my cousin Joanna. Okay, Charlie says, I'm down to get a suprapubic catheter in a couple weeks to rest my bladder. Does this sound like a good plan? Anything at this point that can help me with passing urine? I have to push and strain every time I go. I take Flomax twice a day in Proscar. They say my prostate isn't enlarged. I have tried to cath myself, and that didn't go well and didn't do it. Charlie, do they have an idea why? I mean, is it just, number one, you wouldn't be the first to have a suprapubic catheter for a period of time. It would certainly give your bladder an opportunity to rest, but it is a major surgical procedure to have done and then reversed. But that said, to be able to not have to deal with this constant sensation of fullness and needing to pee, it would be nice to have a break from that. But are they thinking that this is nerve-driven or muscle-driven? Or do you have a neurogenic bladder? Do they really have an idea as to why this is happening? And if you've already explained it, bear with me and just refresh my memory here. Renee says, does the IC Network have a supplement to help prevent candida? No, we don't, because in my opinion, the most important thing to do with candida, as I have in that article that I just linked, is to stop the sugar. If I could have you do anything, it's just stop the freaking sugar in your diet. Stop feeding it. Sherry said, that's lovely. Yeah. Yeah, she had a very hard life, very, very difficult life. And there wasn't anything, it was hard because we were just 3 months apart. But she moved halfway across the country with her family. And I think everybody hoped that I would be like that stabilizing, calming presence, but it just couldn't happen. I tried. It just didn't work. Renee says, yes, I'm trying no sugar. Yeah. That's hard. It's really hard. The problem is that our lives and our diets revolve around processed carbs and sugar, from the pasta to the breads, all that sort of stuff. If we could just get back to rice and fresh vegetables, fresh proteins, we would be so much healthier. Charlie said, they really don't know why I have pelvic floor dysfunction and do physical therapy, ulcers in my bladder that keep recurring. Charlie, have you had I think it would be perfectly reasonable to have a viral test. Have you had that done yet? I mean, given the fact that your lesions keep recurring over and over and over again, that kind of marks, that kind of supports perhaps a viral infection. They can't tell you why you have to strain. Okay. I'm going to tell you a story. I'm not saying this is you. Okay, I'm not saying this is you, but I want to give you an example of another gentleman I worked with who was kind of doing something similar. So, he had not had normal bowel movements or urination his entire life. It was, and he was diagnosed with IC, very, very dysfunctional bathroom, just very, very dysfunctional. And when he finally got to me, and we had a nice long chat over the phone, he told me something that shocked me. Well, I usually say, well, what's your guess? Why do you think this is the way this is? Do you have any idea? And he said, yeah, my mom forced me to have a bowel movement every morning before I went to school. And if I couldn't have one, she forced an enema on me. Can you imagine? Every single day in elementary school, until I think finally he got so big she couldn't do it. She forced an enema on him. And so this little kid, desperate to not have an enema, strained and strained and strained and strained to have a bowel movement to please his mother. Renee says horrible. Yeah, and that's a true story. And he was never, it was like, the thing we have to look at as our brains develop as we get older, it's an amazing process. Like 50,000 new nerves are grown every day in a developing baby. And that continues as we get older. And then finally, our brain usually hits full capacity in our early 20s, and for men, a little bit mid to late 20s, I think, is when the male brain finally is done with that. Not that we're ever done, but anyway. And so his brain was literally taught to do that. Taught to do that. That normal was straining. That was his normal. And he was shocked when he went to physical therapy that his muscles were just toast. They were so freaking tight that there was no shot of him being able to relax them enough so that he could have a normal bowel movement. And, you know, I can remember with my IBS back in my 20s, they were always very crampy and painful. Painful. I called them bend over and screamers, and they were food sensitivity driven. And I can remember how shocked I was once I stopped the irritant to have a normal bowel movement where it was a normal urge. It's just like I woke up, I was fine, ate breakfast. Oh, have to have a bowel movement. Go in. Wow, I just had a bowel movement with no distress, no pain at all. It was shocking. I'd gotten so used to years and years and years of cramping. So I'm not saying that that's you, Charlie, but because but that gives you an example, at least one example of how something like that can occur. But I think more importantly, Charlie, for you, when you're working with a physical therapist, are your muscles improving at all? Or are they locking down right back down into tension? Are we seeing any slow but steady decrease in muscle tension? Or are you always locking back down into tension? Because the second thing that makes total sense is that you've got a bony structure abnormality that's putting pressure on those muscles. Do you have one leg longer than the other? Do you have a bad hip, a bad SI joint, a bad knee, or more importantly, a bad foot? Because it's actually the feet and how you walk that can keep your muscles locked down tight. And let me, I can get a picture. Mary Jo, do you have any info on bladder builder causing kidney stones? I've had horrid recent kidney stone problems. No, I don't. Kidney stones, have they identified the type of kidney stones that you have? Are they oxalate, calcium oxalate kidney stones? Have you started drinking a lot of almond milk? I don't have any data at all. I mean, let me look it up here real quick. I'm going to look up chondroitin kidney stones. Let's see. No, chondroitin sulfate may help reduce the risk of kidney stone formation. One trial found that glycosaminoglycans significantly lowered urinary oxalate level, which reduces the risk of stone formation. Yeah, chondroitin sulfate and heparin sulfate exert a stone inhibitory effect, while hyaluronic acid promotes crystal growth. Oh, wait, hold on. And also remember pre-leaf. If you're taking pre-leaf, all that calcium has to go somewhere and it could cause stone. So hold on a sec. Hyaluronic acid had no effect on stone formation. And this is from a 2019 research study. On the other hand, I will say that there has been a pretty significant increase in kidney stones because of the increased consumption of almond milk. Almonds are high in oxalates. All right, so getting back to this, Charlie, this thing about the feet. So why are your muscles locked down into tension? And it was Dr. Jerome Weiss who really nailed it. So he was really baffled. I mean, you know, he was the first urologist who saw that bladder therapies didn't work for most IC patients. He was the first urologist to completely immerse himself in muscle structure and muscle health and bone health. And he became an absolute master at manipulating muscle. If you walked into his clinic with tight muscles, you would walk out with good muscle tone. He was a master at pelvic floor relaxation and myofascial massage. But what baffled him is in his career is why did some people have muscles go right back into tension? They'd call a week later or a month later and say, my trigger points are back, my muscles are back. He's like, how is that even possible? They were gone when you walked out. I fixed that. And that became the last big question of his career. And he studied this for about 15, 20 years. And in the end, it was looking at bones. It was a podiatrist that helped him figure it out, that 95% of his patients with long-term muscle tension were not walking normally. It was how they walked that was keeping their pelvic floor in tension. And this is the best picture I can give you. Okay, so this leg is straight. And I want you to look at the shin. You look at, it's a 90-degree angle from the ground, straight up. And when we get to the femur, it curves out slightly. And now you can see the muscle attachments for the piriformis muscle right here, right? Now look what happens if you have an ankle that rolls inward. So immediately the shin is at an angle. You see that? This is straight. This is at an angle. And that angle is exaggerated now at the femur, right? So now we're at a significant angle outwards. And look at what it's doing to the piriformis muscle. That muscle is now stretched like 30% more. So here's the healthy muscle. Here's the tight muscle. So imagine the toll that this ankle rolling is going to have on the pelvic floor over time, especially if you walk a lot. That's an undeniable, you can directly see how your feet are going to mess up your pelvic floor if you don't walk correctly. So the other thing, Charlie, is I would, if the doctor, if they can't find a cause, you know, a muscle cause, I would have them watch you walk. And let's see if you're walking normally. So as an example, for me, when I went to the, so my regular physical therapist did the internal work, but the problem is I still had a lot of pain in my left butt cheek that was interfering with how I was sitting. And they just said, Jill, you just have messed up muscles, you have torn muscles, they're scarred, you just need to stretch them out. And I did for 10 years, and I was getting worse and worse. And finally, I just threw up my hand. I went, all right, I'm going to a sports physical therapist because I was a professional athlete in graduate school. I was a nut, okay? I mean, I was a nut when I was in college with athletics. I loved running upstairs. I did 100 flights of stairs a day, not having a freaking clue the damage that I was doing. A lot of damage I did. And I did that for years. All right, so when I went to the sports physical therapist, and he had me walk up and down the hallway. He goes, oh, that's really weird. Do you realize you don't walk in a straight line? And I'm like, no. He goes, you walk like this. You favor one side. And I'm like, really? I've never noticed that. I walk up and down. He goes, yep, you're doing it. Absolutely doing it. And he was the one who figured out it was my SI joint. It's your SI joint. And once I started doing the correct exercises instead of the stretching, it was night and day. It's like, oh, okay, this is it, right? Charlie said, yes. I roll my one ankle. Oh, there you go, Charlie. I'm loose for 24 hours after physical therapy and then right back to tight. I've been a nurse for 24 years, so yes, you're on my feet a lot. Charlie, are you wearing Hokas at work? What shoes do you wear at work? I gotta show you the shoes. I gotta show you these shoes. Hold on. Hoka One shoes or Hoka 11 shoes are the top recommended choice for people with funky feet. Okay, hold on. Oh, what? No. Okay, hold on. These are the shoes that I wear. And I'm telling you, they've given me my life back. I can't tell you the number of steroid shots I had in the bottom of my feet for all the damage I did. I did so much damage to my feet and to just by doing, I was obsessive about Stairmaster. I ran up Diamond Head, for God's sake. Give me something to run up. I loved running up hills. Didn't like coming down. I loved running up hills. All right, hold on. So Hoka's, I'm gonna give you this link. You got to check these out, and they come in white, but they come in lots and lots and lots of colors. I have like 10 pairs of them now. They're like literally the only shoes I wear along with Teva flip-flops. Mary says, I do everything right. I'm thinking about trying Bladder Builder. I ate very carefully. Just had surgery 5 weeks ago to get out of my kidney. Thanks for checking. Mine are oxalate, big ones. Wow. So do you know, Mary Jo, you know the high oxalate food, so no spinach, no berries, no chocolate. Here, let me grab a pair of my Hokas. Hold on so you can see them. You know, one of the gifts of being older is I don't have to try to please other people by wearing high heels anymore. So this is my newest pair of Hokas. I wore them yesterday, as a matter of fact. Right? And these are the Bondies. Incredible cushioning under the balls of the feet. This is another pair, one of my favorite pairs. I can walk miles in these shoes. I couldn't walk 10 minutes before they fixed everything. Now I can walk miles, and I do walk miles usually every day or every other day. And I need to walk today, as a matter of fact. I usually walk after I do my meeting. So check these out. But Charlie, you got to get that. You got to work on your ankle. You got to go to a podiatrist. And the book, get this book, hon. You can get it from the IC Network shop. It's $6 cheaper than Amazon. Breaking Through Chronic Pelvic Pain, a Holistic Approach for Relief by Jerome Weiss. It will help you be a better nurse, I promise you. This book is the Holy Grail Bible of all things neuromuscular in the pelvis. And I'll make a deal to anybody. If you buy this book from the IC Network and it doesn't help you, I will buy it back from you. It's that good. It's insanely good. So let me see if I can. And it's filled with really good case studies. Okay, treatment of foot abnormalities. Foot problems can alter body mechanics, leading to stresses in the lower extremities and pelvis. Therefore, effective treatment of pelvic myofascial or pudendal nerve problems requires that foot abnormalities receive appropriate concurrent therapy. The following progression of treatments can be used to reverse foot abnormalities associated with pelvic pain. Number one, stiffer, more supportive shoes can generally improve overall foot functioning. Over-the-counter inserts. Got to be careful with the over-the-counter inserts, though. I used Spenkos for years, but the Hokas don't need any inserts at all. Functional orthotics should be considered when there's significant abnormal flattening of the foot or normal functioning of the foot, leg, hip, or knee. That might be true. So, Charlie, my dad has the same thing. And the reason why his ankle rolls in is because he actually tore a ligament or something. Something got torn about 10 years ago. And now his ankle rolls in. And if they had caught it earlier, they would have surgically repaired it. But it's 100 years old now. So, yeah. So here we go. A 50-year-old man had been seeing me occasionally over a 10-year period for intermittent perineal pain. I'd been treating his tight pelvic floor muscles and trigger points with internal manual therapy. And though he received great relief from these treatments, pain flares inevitably occurred. Frankly, I had never completely understood the mechanics of his symptom flares until he came in one day complaining of hip pain while walking. This led me to question him further and ultimately put us on the right track. I asked if there were any other musculoskeletal problems that he had not thought to mention previously. He responded that he'd always had pain at the base of his large toes, which he attributed to arthritis. But because he knew other family members had the same problem, he never sought attention for this congenital issue. I then examined his feet and found bunions and moderate overpronation. At that moment, the light turned on. I'd found the origin of his hip pain. And podiatric treatment eliminated his flares. Here's another one. 65-year-old woman came to see me with a history of recurrent frequency urgency and urethral pain without infection. Examination revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual therapy, to which she responded positively. However, she continued to have pain flares. While my treatments were effective in the short term, the results only endured for variable periods, and I continued to administer periodic therapy for nearly 10 years. At the time of her last visit, armed with new knowledge, I looked at her feet and I noted unusually high arches. When I asked her if she had experienced any potential side effects from such an apparent abnormality, she came out with bilateral Achilles tendonitis, knee surgery, and more recently, hip pain when awakening or rising from a crouching position. In my mind, I visualized a straight line of mechanical stresses. It began with a foot imbalance, which affected the Achilles tendons, then the knees, hips, and ultimately pelvic floor. And she went to the podiatrist and got better. And he summarized, 10 years ago when I first saw this patient, the feet seemed too distant from the pelvis to be considered in the treatment plan. Experience has taught me otherwise. Oh, wait. Hold on. This might even be better. A 42-year-old man with voiding difficulty reported that at age 14, he had severely fractured his left foot, leaving him with a short leg. Since that time, he had assumed many abnormal positions to prevent sitting on the leg. Within a year or so of this injury, the voiding difficulty began, and he was too embarrassed to mention the problem to his parents until another year had passed. He was subsequently found to have tightness of the pelvic floor muscles, which is typical of voiding problems, and had limited success with physical therapy and biofeedback. When I examined him, the short leg was apparent, as well as externally rotated legs and a severe overpronation of the feet. And again, the visit to the podiatrist is what fixed it. Jamie says, I have rheumatoid arthritis and wear orthotics, ankle weak from torn ligaments. I've been retired and wearing house slippers. Yeah, house slippers aren't going to get you where you need to go. That's for sure. Gammy, this would be a good book for you to have too. Outstanding book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. He's now retired. He's 80. I think he's 86 now. Just brilliant, brilliant book. Best book ever written for somebody with nerves and muscles. And you know what kills me? What absolutely kills me? He was in San Francisco. I'm up in Sonoma County. I'm at, 90 minutes away. In hindsight, oh my God, I should have been his patient, but my insurance wouldn't pay for it back then. I had the chance to go to the master and I didn't. And it took years and years to figure out my problem. He would have figured it out right away. Oh, so, you guys, listen. There are moments when you always have to remember that you deserve the best. You deserve to work with somebody who's really, really good. Health insurance being what it is sucks. Kaiser Permanente, they have good physical therapists, a small number of pelvic floor physical therapists. Back then, they didn't have them. I should have paid out of pocket to go. I just didn't understand the importance of it. I did not get it, even though I met him several times at conferences. What a lost opportunity. The blessing here now is we've got a lot of really good patients, really good providers, pelvic floor providers. And so if you ever have an opportunity to go see a national specialist and it's a 2-hour drive or a 4-hour drive or a 6-hour drive, for God's sake, go. You can get there. You can get there. Because you will learn more in 15 minutes from a national specialist than years of working with local inexperienced people. So if you're within driving distance a day from Ken Peters up at Beaumont or Robert Moldwin in New York or Robert Evans in North Carolina, for God's sake, go. Because their depth of experience and the fact that they've worked with thousands of patients over the years, you will get more from them than you could. Gammy, I've had the worst foot pain. No, the worst foot pain I had was from Uggs. And I did get I wear an orthotic in anything that's flat, really bad for me. So I wear an orthotic in my Uggs. And then I lived in Birkenstocks for years. I loved wearing Birkenstocks, but they're too hard now. I don't have the fat pad on the bottom of my feet. And so walking in Birkenstocks really hurts. I hate that because I love my Birkenstocks. My feet love them. And I refuse to wear old lady stuff. Listen, my mom's generation, when you were 50, you cut your hair, you got perms, you wore house coats. That's not my generation. I still shop in the junior section. I will never, ever do that, ever. And the shoes that used to drive me crazy are what I call old lady shoes. It's like, I will never wear old lady shoes, ever. You know what I mean, right? SAS shoes, San Antonio shoes that my mom wears. And you know what? I got so desperate. I went to get their version of Birkenstocks. Oh my God. No, they were Hoka's. Hoka's all the way. Hoka's have given me so much back. So go for the Hoka's when you can. Hoka one one. Or when my feet hurt so bad, anything. Exactly, right? All right, guys. Well, we've been doing this for about 3 hours now. So I'm going to do a last call for questions. Any other questions? Otherwise, I'm going to go do my walk. although I shouldn't because I have to wait until I get my mom to the bathroom and back. So I'll probably have to wait 45 minutes to do that. Last call for questions. Last call for questions. Any other questions? And you guys, when I'm looking over here, I'm looking at YouTube. And when I'm looking here, I'm looking at Facebook. That's why I keep looking that way. Oh, there's my mouse. Last call for questions. Last call for questions. All right. Well, listen, if you like these meetings and you like what I'm saying, please come on over to the IC Network, icnetwork.org. Sign up for our free newsletter. If you can, I'd really appreciate it if you could share our website with your IC friends on social media. That would be great. You can share videos. You can share this stream. These are all recorded, so you can come back and watch them. Mary Jo said, I've had IT for many years. Girl, me too, hon. Mine started at the age of 14. 50 years ago. Christine said, have you heard of any new medication studies for IT? Oh, Christine, girl, what a fantastic question. Because in the end, listen, there's no such thing as a medication for everyone. So your question is a bit flawed. You can't, so you have to remember, now listen, there's a very happy ending here. Okay. If you come to any support group, you're going to learn that there's tremendous diversity. For some people, their symptoms start in childhood. For others, after menopause. Are they the same? No. For some people, IC begins after chemotherapy, while for others, it begins after falling on their tailbone. Are they biologically, anatomically the same? No, they're not. Absolutely not. And when you look in the bladder, you really see the diversity because about 5 to 10% of patients have Hunner's lesions, but the rest of us have normal bladders, maybe a little inflamed, but normal bladders. So, and what have we learned? That bladder treatments over time don't work for the vast majority of patients. Why? Well, because most of us have healthy bladders. And if you look at our new guidelines for IC that were released 11 months ago, this is what it says. There is no disease process happening in the vast majority of IC patients' bladders. The only patients who have a disease process are patients with Hunner's lesions or infections. For the rest of us, it's a neuromuscular disorder. It's being driven by dysfunctional nerves and dysfunctional muscles that are damaging the bladder or victimizing the bladder. So, and this is also, I spent a lot of time working with companies, and I want companies to succeed. We just had our last fall, for example, we had the National Institutes of Health planning meeting for future IC research, and I was part of that. And the point, everybody now admits and understands that you can't put apples, oranges, and bananas in the same treatment and expect the same results. That there is very clear diversity, and each patient group has its own treatment. So, are there new medication studies? Absolutely, but it depends upon your subtype. So, are there no treatments underway for Hunner's lesions? Yes. Are there new treatments underway to try to calm the bladder wall and calm the nerves? Absolutely. I've just sent out 4 clinical trial announcements to the IC Network newsletter list. So if you want to hear about all these, all you have to do is go over to icnetwork.org and sign up for our free newsletter, and you'll hear all about that because we're sending you the opportunity to participate in these new studies for these new experimental treatments. And they're valid, they're logical, they passed their animal studies successfully, and we've got good baseline data, and now they're trying to get through the FDA approval process. Are there new treatments for pelvic floor dysfunction? There are new treatments to refine and perfect how myofascial massage is doing, because the best treatment for pelvic floor dysfunction is hands-on work with muscles. And we have the research to prove that. Are there new treatments to try to calm nerves down? Absolutely. They're working on that all the time. So for patients with pudendal neuralgia, we want to release the muscles that are compromising the nerve, and then we need to directly calm the nerve down. PEA, palmitoyl ethanolamide, is an example of that. Are there new therapeutics that are being developed to try to calm the central nervous system down and to get that patient out of fight or flight? I'm not sure. To be quite honest, I'm not sure. But I can check. The Chronic Pain Research Alliance is the team that's doing that. Let's see. chronicpainresearch.org. They're the ones that are doing all the fantastic research. Find about the latest research findings. Let's see. Let's see if there's anything new. The last one was in October, so nothing in the last 6 months that they've done. One study that's going on at UC San Francisco is no, I'm sorry, not at UC, the University of Southern California, by Jason Kutch, who's a pelvic pain neuroscientist. They're using magnetic brain stimulation to try to calm the central nervous system down and to break that brain out of fight or flight. And that's very, very exciting. So again, it's about what is your subtype. We have to find the right treatment based upon your unique subtype. So it's very exciting. It's a great time right now. We have made more progress in the last 2 years, I think, thanks to COVID and really people being forced to work at home and having a lot more time for science than before. It's a good, exciting, encouraging time for the IC world. Okay. All right, my friends, I wish you well. Hopefully on Facebook, I will come to a live meeting on Thursday or Friday. I couldn't do one this week because I was working with the patients who were in deep crisis, and they always get preference for me. So if the time is available, I'll do a drop-in on Facebook on Thursday or Friday. Otherwise, hopefully you'll see me next Sunday, knock on wood. Thank you all for your good wishes for caring for my elderly parents. Obviously, we're getting near the end. So it's Dad's in a lot of pain every day now with GERD. It's really bad. And my mom's legs are not working so well anymore. So she's barely able to take a step. So send me your strength. Life, right? What a journey we're on. But it's great that we're able to do it together. All right. I'm going to say goodbye to Facebook. I'll see y'all later. Have a good one.